He's a national faculty of PSCO with commitment to training advancements for future oncologists. We are also joined us by a powerhouse jury, Dr. Naeem Haider, Dr. Amir Maqbool, Dr. Kamran Saeed, and Dr. Azhar Rashid, and Dr. Abdul Ghafar. In the interest of time, we'll be taking questions at the end of the session, and I request the judges to kindly start marking as the presenters are presenting. To start off, we have a critical look at precision in brachytherapy, specifically comparing fixed configuration versus image-guided needle insertion in cervical cancer. From CMH Lahore, please welcome Dr. Mariam Ijaz.
Assalamu alaikum. I am Dr. Mariam Ijaz, resident radiation oncology at CMH Lahore. Today, I will be discussing our study regarding needle insertion approaches in cervical brachytherapy, whether a fixed configuration approach is dosimetrically comparable to the standard of care image-guided needle insertion. I'll first start with the logistics behind our research question, followed by the study we conducted as evidence. Before we discuss the research question, first let's see the standard of care which is followed in our department as well as in many other hybrid brachytherapy patient setups in Pakistan. First, the patient is a locally advanced CS cervix patient, FIGO 1B2 to 4A, ECOG 0 to 2, who has undergone external beam radiation 45 grain 25 fractions with concurrent cisplatin and is now being planned for brachytherapy 28 grain 4 fractions. On the day of brachytherapy, the patient is first prepared. The applicator is inserted, which is the Utrecht tandem and overt applicator in our setup. Then the first CT scan is done for needle measurement, and then the needle is inserted. Then another CT scan is done for planning. Then the oncologist delineates the CTV and organs at risk and collaborates with the physicist for planning, and then the treatment is delivered. In this workflow, our question was, are the two CT scans really needed in every case? The first for guidance and the second for final treatment planning. The CT simulator might serve as a logistic bottleneck in many setups in Pakistan, as there's a single CT scanner for both the brachytherapy patient, which would take 20 to 40 minutes for the two scans and needle insertion, as well as for the other external beam radiation patients. So it might be a cause of long wait times for both of these kinds of patients. So our approach was to insert 6 lateral needles at a fixed depth of 2 centimeters each with no scan done for guidance. Only one scan was done for planning. And as you can appreciate in this CT scan, 6 lateral needles have been inserted to a fixed depth of 2 centimeters, and there is adequate dosimetric coverage as well as pairing of organs at risk as seen in the DVH as well. So our objectives were to compare the fixed configuration and standard of care dosimetry and to evaluate the acute organ at risk toxicity as well. We had 46 patients and 181 fractions. The first analysis was the perfect fraction analysis, 93 patients from the fixed configuration cohort and 88 from the standard of care. The secondary analysis was also done for per patient analysis, 17 patients in the fixed configuration and 14 in the standard of care. We had to exclude 15 patients as they had heterogeneity of techniques, as we did allow for flexibility in the techniques. If after the first scan, the oncologist determined that another needle or a deeper needle is needed, the oncologist could use that first scan for needle depth measurement, followed by the second scan for the standard of for the planning purpose. In that case, it would be standard of care. Our targets were according to the Embrace 2 protocol. The patient selection was done as we previously discussed. A patient of locally advanced CS cervix who has undergone concurrent chemoradiation followed by brachytherapy 28 grain 4 fractions. After data collection and analysis via Mann-Whitney test, the results were interpreted. The high-risk CTVD90 dose per fraction difference was statistically insignificant. The bladder dose per fraction difference was also statistically insignificant with a p-value of 0.98. A difference of 4. All of the dosimetric differences were statistically insignificant, including the sigmoid dose, which the difference was washed out in the per patient analysis. We also did a toxicity screen of the patients, and there was no grade 3 to 4 toxic event in the bladder, rectum, sigmoid, as well as in terms of per-op and post-op hemorrhagic events. So the study was not only clinically feasible, but safe as well. The benefit we attained from this study was that our procedural speed increased. We adhered to the ALARA principles as multiple CT scans were not needed in every case. It's a solution for settings where resources are low and burden is high. And although MR brachytherapy is the gold standard, where the resources are low, the fixed configuration approach can serve as a fallback strategy. So to conclude, the fixed configuration approach is dosimetrically equivalent to standard of care with negligible organ at risk toxicity and good workflow efficiency, and it's a good fallback strategy in the lower middle income settings. Thank you very much.
Thank you so much, Dr. Mariam, for sticking to time. Now moving from the cervix directly to the brain, we have Dr. Tayyab Babar from Noori Islamabad discussing treatment outcomes of stereotactic radiotherapy from brain mets using CyberKnife.
Respected seniors and dear colleagues, Assalamu alaikum. I'm Dr. Tayyab, and I'm a final year resident radiation oncology in Noori Hospital. And I will be presenting our study on treatment outcomes of patients with brain metastasis using CyberKnife, a single center experience using different dose levels. So I have nothing to disclose. This is my presentation overview. So starting with the introduction. So traditionally, whole brain radiotherapy has been used for treating the brain mets, treating the whole brain. It takes a longer time and affects the cognitive function. While the stereotactic radiotherapy takes shorter time and it preserves the cognitive function. So CyberKnife is a frameless radiotherapy system, image guided, and 6 MV Linux is on a flexible robotic arm, and it is accurate as SRS and conformal as IMRT. And the objective of my study was to evaluate the efficacy and toxicity of stereotactic radiosurgery and fractionated radiation therapy in brain metastasis using CyberKnife. So starting with the methodology, the patient from January 2023 to June 2025 were selected and treated with single or multiple fractions, and these are all of patients of brain mets and decided in neuro-oncological MDT, and it was a retrospective cohort analysis, and patient with poor performance status were excluded. So patient simulation was done in supine position with CT scan and MRI in 1 mm images, and the PTV was GTV with 1 to 2 millimeter margins. So there was 3 dose fractionations according to the increasing biologically effective dose. Dose level 1 included 21 to 24 gray in 3 fractions, or 20 to 30 in 5 fractions, and dose level 2 included 27 in 3 fractions, or 18 to 20 gray SRS. And dose level 3 were 21 to 24 gray in single fraction. So the treatment plan, you can see the coverage of the 95% dose, covering the whole of the PTV. And SRS was, single fraction was used for smaller lesions and away from the organs at risk, while the fractionated radiotherapy was, I guess, given for larger lesions and near the organs at risk, and all the patients received steroid during treatment. We used the UK 2022 OER guidelines, and there was, you can see, one of the plan coverage of the GTV, and there was sparing of the organ at risk. So if we could not meet the dose constraints, we modified the total dose or the number of fractions accordingly. So response evaluation by the RECIST 1.1 criteria, and the local tumor control were defined as complete response, partial response, or stable disease, and overall brain control was defined as no new brain lesion developing during the follow-up. So the partial response was more than 30% reduction in the lesion. Progressive disease was more than 20% increase in the lesion. CR was disappearance of the lesion. And stable disease included all other responses. So use SPSS 26, and RP class was assigned to each patient. And the endpoint were the local tumor control, overall brain control, and overall survival. And it was done using the Kaplan-Meier method. The follow-up was 1 to 3 month intervals with neurological examination and MRI, and any new brain lesion was graded as overall brain failure, and any progressive disease was labeled as local failure. So there were 28 patients with 55 brain mets, and median tumor max diameter was 2 centimeter, median tumor volume was 3.84 cc. So the mean age was 55, and most of the patients were less than 65 years of age, and mostly were females, and with the KPS of more than 70. And the RP class was 14. The RP class 2 was most common, and extracranial disease was 14 and 14 equally divided. And most of the patients were of CA breast, and most were solitary brain mets, and mostly in the dose level 3, the SRS group. And headache and dizziness were most common in each of the patients. And this is the characteristic of the brain mets. And there were smaller lesions, less than 8 cc lesions were treated mostly with dose level 3 SRS, and followed by dose level 2. And the most common was primary breast. And as you can see, single fraction was used in dose level 3 and multiple fraction in dose level 1. So most of the tumors were present in the parietal lobe, followed by the cerebellum. And the BED was, dose level 1 was around 36 gray median BED, and dose level 2, 51, and for the dose level 3, it was 60. And isodose level and whole brain doses have been given. So the median follow-up was 5.5 months, and range from 1 to 34 months. And median overall survival was 16 months. And overall survival of the patients were 82% at 6 months and around 75% at 12 months. Local tumor control rate of the 55 brain mets was 93.6% at 6 months and 90% at 14 months. So there was CR in 2 patients, and 4 patients had progressive disease. And the dose level 1 had 79% local tumor control at 14 months. Dose level 2 had 93.2, and dose level 3 has the highest local control at 14 months. So this was one of the patients who achieved CR after SRS. So this was the largest region we treated, around 40.85 cc. Showed increase in necrosis after fractionated steroid-directed radiotherapy. Overall brain control was 88 and 83% at 6 and 12 months, and acute toxicity was minimal. A few patients had headache and hypertension. And regarding the size, with 50, there was almost local tumor control same at 6 and 12 months, except for the 15 and 33 cc lesions, which the local tumor control decreased from 85.7 to 68.5%. So this is my overall survival curve. This is the local tumor control was better. According to the dose level 3 had the highest number of follow-up, and the dose level 1 had the poorest local control, as seen from the graph. Also, you can see with the size, the smallest lesion had the longest follow-up, up to 30, and the 15 to 33 cc lesion had the poorest local control. So this is the overall brain control curve. So these are my reference studies, and with the local tumor control ranging from 76 to 84, and median OS from 13 to 26 to 20. So these are my limitations: small sample size, and there was poor patient follow-up, affordability in some patients, and clinical symptoms were not recorded for some patients. So the summary: 28 patients with 55 brain mets were treated with 3 increasing BED dose levels. The median follow was 5.5 months, and median overall survival was 16 months. 6 and 12 month overall survival was 82 and 74.8%, and 6 and 14 months local tumor control was 93 and 90%, and overall brain control of the 28 patients was 88 and 83% at 6 and 12 months. And the smaller tumor size and the higher BED had a better local tumor control and overall survival. And these were comparable to the other reference studies. These are my references. Thank you all for your patient listening.
Thank you, Dr. Tayyab. Shifting to head and neck oncology, presenting on the outcomes of hypopharyngeal squamous cell carcinoma, we have Dr. Jawad Latif from Shaukat Khanam, Peshawar.
Bismillahirrahmanirrahim. Thank you so much. Thank you, respected jury and dear colleagues. My name is Dr. Jawad Latif, and I'm currently working as a resident doctor at Shaukat Khanam Memorial Cancer Hospital Research Center in the Department of Radiation Oncology. So today's topic is regarding one of my prospective study that is clinical and radiological outcome in non-metastatic hypopharyngeal squamous cell carcinoma patients that were treated with the carboplatin paclitaxel-based induction chemotherapy followed by concurrent chemoradiation. So the background is we all know that hypopharynx is very aggressive tumor and rare malignancy in the head and neck cancer, and it has a very poor survival outcome. So the concurrent chemoradiation with cisplatin is the standard of care, as we all know. But since the cisplatin is very toxic chemotherapy and it is very poorly tolerated in our part of the world and our population, so therefore our consultant has decided to treat some patients differently with the carboplatin paclitaxel as per their clinical demands. So why did I do this study? Because I've seen the patients that the median survival as per the EORTC phase 3 trial of the hypopharynx were only median survival is 18 months. But since our patients were having a good follow-up for more than 2 or 3 years, so I did this study, and there is very limited data available, prospective data available from our part of the world in the hypopharyngeal squamous cell carcinoma. And since the carboplatin paclitaxel has demonstrated in the newer guidelines that it is not even a better tolerable, but it is also good efficacy with a good outcome. So the study design was prospective observational study. It is a single-arm, single institutional-based study from the radiation oncology. It is conducted after an IRB approval. It is a non-randomized and non-comparative study. The objectives are, the primary is to assess the clinical and radiological responses for the research criteria, and secondly is to evaluate the toxicity, and later on to see the DFS and progression-free survival. So the methodology, I've included all those patients after ethical and IRB approval with the non-metastatic hypopharyngeal squamous cell carcinoma who were intended to be treated with the carboplatin paclitaxel-based induction chemo and then concurrently with chemoradiation with the same chemotherapy regimen. The responses and toxicity were tolerated, were assessed during after completion of the induction chemotherapy, and then the patient were encountered at each follow-up during concurrent chemoradiation, and then after the completion at 6 months, 12 months, and 18 months. So total patients included were 73, but 16 of them were excluded due to the reasons that they were treated with somewhat different treatment as per their clinical demand. So and some of them lost their follow-up after completion of induction chemo or during their concurrent chemoradiation. So 57 evaluable patients were assessed. Male patients were more than 32:25, male to female ratio. So most of them, as we know that hypopharynx is an aggressive tumor, so they mostly present with a locally advanced stage. Stage 3 patients were 39, and stage 4A patients were 24%. The post-cricoid region was being the most common subsite. 46 patients were from the post-cricoid region. That is 81% of the total population. Coming to the results, is this bar chart demonstrate that the complete radiological response and clinical response was noted in 51% of the total population, that is about 29 patients. So it's remarkable. And the partial response and progressive disease were noted in 14% of the patient, that is 8% of the total population, 8 patients of the total population, and 21% had a stable disease. So the toxicities were divided into the acute toxicities that occurred in the first 90 days, and then late toxicities were noted as xerostomia afterward in the last follow-up in 43% of the total population. Coming to the survival outcome, so the median survival is 58 months, almost for DFS and PFS, 80 months at 12 and more than 80% at 12 and 18 months. So this demonstrates that the carboplatin is not even better tolerable, but also an effective treatment for the patients who has got non-metastatic hypopharyngeal squamous cell carcinoma. So it is a viable option for the patients to be treated with this regimen. Obviously, there are limitations and to my study because it's a single-arm, non-randomized, non-comparative study, and it has a limited sample size because of the limited time available to conduct this study. And I would want to conduct a clinical trial proceeding the future to be better, to come with the better results afterwards in the future with this regimen in induction and concurrently with radiation. Thank you so much, everyone.
Thank you, Dr. Jawad. Okay, for the next session, I will be staying on the podium to present my own institutional experience of multifraction stereotactic radiosurgery for benign meningiomas. Good morning. My name is Dr. Zainab Rafat Ali. I am a postgraduate resident at NCCI Hospital, and today I will be presenting our institutional experience of clinical outcome of fractionated radiosurgery in benign meningiomas. So imagine a patient comes to you with a radiological diagnosis of a meningioma, and we have a menu of treatments to choose from. First up, surgery, great, but invasive. Then we have conventional radiation, effective, but takes a lot of time. Single fraction radiosurgery, fast, but risky. So the new norm is fractionated radiosurgery, safe and comfortable. This brings us to the background of our problems. You see, fractionated radiosurgery sits comfortably right in the middle of single fractionated radiosurgery, which offers high tumor control at the expense of toxicity, whereas conventional XRT may be feasible, but logistically is bothersome. So as the philosopher Thanos would say, perfectly balanced as all things should be, we wanted to deliver the punch of high tumor control, but with minimal toxicity. And we were not the first to do so, obviously. Literature of hyperfractionation shows that if you fractionate, you maintain an elite level of control between 90 to 100%. But the magic is that toxicity drops significantly as compared to single fractionated radiosurgery. It's like fractionated radiosurgery is like Diet Coke. It gives you the hit of tumor control, but does not give you the toxic necrotic calories. So against this backdrop, we present our institutional experience of fractionated radiosurgery in benign meningiomas. Our objective is pretty straightforward: to evaluate its efficacy and safety. So we analyzed about 100 patients. The mean age was 44 years, and majority of them were female. You see over here that they occupied some major parking spots in the brain, CP angle really close to the brainstem, or suprasellar region very close to the pituitary and optic apparatus. Also to note here, about a third of our patients had comorbidities. Remember this, as this will be very essential later on. So what did we do? As I mentioned, we retrospectively analyzed 100 patients over 6 years. who we treated with clinic-based radiosurgery. Prescription was 25 gray in 5 fraction. Monday to Friday, consecutive days, weekends are off, or as I like to call it, how to not spend 6 weeks in my waiting room. So for the physics lovers, BD sits nicely between therapeutic window, enough to kill the tumor, but not enough that optic operators will file a lawsuit. So our efficacy was excellent. Only 6% of the patients showed progression. Clinically, over a third of the patient didn't just stabilize, they actually improved symptomatically. 71% of the patient achieved disease control and 37% improved in symptoms, meaning their quality of life actually improved post-treatment. The mortality that you see here, it is not governed by the tumor size or the treatment, but because of the mortality of the patient. So it's essentially that we deliver 25 gray in 5 fraction, the tumor stops growing, we get 90% survival, but the patient refuses to control their diabetes. It's like we can control the tumors, but we can't stop the gulab jamuns. So for the skeptics here who would say pictures or it didn't happen, here is a right cerebropontine angle tumor causing significant mass effect on the brainstem and right cerebellum. And here it is 6 months post-XRT. Here we see a large midline anterior skull-based tumor with significant superior extension into the bifrontal region. And here it is post-treatment showing volume shrinkage. So this is our key finding. We achieved a 5-year overall survival of 90%, and statistically, mortality was driven primarily by the patient comorbids, not treatment failure. So basically, the tumor size tried to kill the patient, but the diabetes tried harder. So safety is where this regime shines. 95% of the patient had 0 acute toxicity, and long-term toxicity was also minimal. So this was a stark contrast to high edema rates seen in single fraction. So when we see diagnosis of a large skull-based tumor, we do not need to worry. It is possible that 5 years later, there will be no toxicity, tumor will have shrunken, and there will be vision improvement as well. This brings us back to our humble attempt of joining our research to already growing data on hypofractionated stereotactic radiosurgery. Our data shows a control rate of 88% and a volume reduction of 20%. In conclusion, 5-fraction stereotactic radiosurgery balances high tumor control with an exceptional safety profile, making it an ideal strategy for large or complex meningiomas, and directs future need for multi-center prospective trials. Thank you for your time, and I hope I didn't exceed your tolerance dose. Okay, moving on to GI oncology, addressing the total neoadjuvant therapy approaches in rectal cancer and its pathological responses. From CMS Rawalpindi, please welcome Dr. Shahzeeb Javed.
Assalamu alaikum. Good morning, ladies and gentlemen. Today, I present not just data, but a local revolution, evidence that the powerful global strategy, total neoadjuvant therapy, is not only effective, but also practically achievable in our own setting. This is about changing outcomes right here. I'm Dr. Shahzeeb from the Department of Radiation Oncology, Combined Military Hospital, Rawalpindi, and I'll be presenting our data on clinical and pathological outcomes of total neoadjuvant therapy using long-course CCRT in rectal cancer, a single-center prospective study. Colorectal cancer is our nation's second most frequent cancer. While the world advances with trials like Rapido and Prodigy 23, we in Pakistan have been navigating a data desert. We have global maps, but no local compass. This study is a small step to draw that map. The challenge, ladies and gentlemen, in locally advanced rectal cancer is clear. We need aggressive downstaging. The old paradigm was radiation, wait, surgery, then chemotherapy. The TNT revolution flips the script. We hit hard and we hit early, attacking the primary tumor and micrometastasis simultaneously. It's a strategic overhaul that aims for the holy grail, increased rate of pathological complete responses. So, what did we aim for? Our mission was clear-cut, to evaluate in our own patient population a power of long-course TNT. We measured success by 3 tangible metrics: resectability, tumor size reduction, and pathological complete response rate. We did a prospective study with 44 carefully selected patients. We included only patients with stage 2 or 3 rectal adenocarcinoma. And crucially, all patients had to be deemed suitable for surgical resection following TNT. We included adults age 18 and older and an ECOG performance status of 0 to 2. We excluded patients with history of prior pelvic radiotherapy or active inflammatory bowel disease. We specifically excluded mismatch repair deficient tumors and also excluded patients with severe comorbs that would contraindicate the aggressive therapy we were studying. We excluded cases of recurrent disease, patients who could not undergo MRI, and those with a second primary malignancy. Our protocol was deliberate. 4 cycles of K-POX chemotherapy first, followed by long-course chemoradiation, 45 10 25 fractions using IMRT, VMAT technique with oral capecitabine. In some cases, an optional 5.4 gray boost was also given. It was followed by an assessment MRI at 4 weeks to document the clinical response. Then a planned interval surgery at 6 to 8 weeks, followed by assessment of histopathological findings. Each step was discussed in an MDT meeting, so this was evidence-based medicine. Results. So this was our cohort, largely middle-aged, mostly male, low-lying tumors. This was the staging distribution of our patients, showing the more locally advanced cases. It confirmed that we tested TNT in the right battlefield against the right adversary. The clinical response was dramatic. Tumors shrank significantly, making them amenable to surgery, with 37% showing clinical complete response. But the pathological response was transformative. Our PCR rate reached 20.5%. Let me say that again. 20.5% of our patients had no viable cancer left in the surgical specimen. Around 30% patients showed partial response. This isn't just a number. It's hope crystallized into data. But the true test of any neoadjuvant therapy is in the operating theater. Does it translate to a better, safer, and more effective surgery? Let's see. First, the resection margin status. Our paramount oncological goal. We achieved an R0 resection in 81.8% of our patients. In our cohort, the majority of patients, around 61.4%, underwent a sphincter-preserving anterior resection. Now, this is a pivotal outcome, as we weren't just removing cancer, we were preserving dignity and quality of life. For the more distal, low-lying tumors, a proportion of patients, around 38.6%, required an APR, abdominoperineal resection, with a permanent colostomy. However, ladies and gentlemen, it is crucial to note here that in several of these cases, TNT enabled a shift from a non-resectable APR scenario to a feasible curative one. So, where do we stand globally? That's the real question. Our PCR rate of 20.5% sits meaningfully between the landmark trials. It is comparable to the 28% in the Rapido and 27.8% in the PRODIGE 23. However, we must note one key difference in approach. Both Rapido and PRODIGE 23 either utilize a short-course radiotherapy or more intensive chemotherapy backbone like FOLFIRINOX, followed by consolidation chemo. Our choice of long-course chemoradiation was deliberate. It is the platform technically mastered in our center. The fact that we achieved almost similar PCR rates is a powerful evidence that the versatility of TNT principle is applicable across different technical platforms. Our APR rate of 38.6% is where we must apply careful context. A higher baseline APR rate was anticipated, but is it a protocol failure? I think that it's a patient population signature. The reason is clear, ladies and gentlemen. Global trials often have strict exclusion criteria for very, very low tumors with sphincter invasion at baseline. Therefore, TNT's success here is not measured by preventing APR, but by ensuring that when APR was necessary, it was a curative R0 resection. Our results also present a point for honest discussion. Our R0 resection rate, while strong at 81.8%, may appear numerically modest when placed against some international benchmarks, which often report rates exceeding 95%. So we must revisit who we were treating. Our cohort was heavily weighted towards locally advanced with threatened margins at baseline. In global trials, patient selection often excludes the most anatomically challenging cases. We did not. Second, the interval between chemoradiation and surgery. This is a delicate balance, ladies and gentlemen. While we followed a 6 to 8 weeks window, emerging data suggests that extending this interval, allowing more time for tumor regression, can further increase R0 rates. Third, we operate within a resource-aware ecosystem. Variations in imaging resolution, surgical instrumentations, in the high-resource trial centers can subtly influence margin clarity. So total neoadjuvant therapy with long-course chemoradiation is a successful and practical strategy for Pakistan. But we are not stopping at surgery. As was being discussed yesterday between Dr. Sarish and Dr. Sadaf, that our next approach is watch and wait protocols. We built this work on the shoulder of giants, and we thank them. I thank you all, and I'm sorry that I exceeded my time.
Next, we look for workflow efficiency, a vital topic for resource-limited settings, presenting on reducing pediatric radiation therapy delays from Aga Khan University Hospital. Please welcome Dr. Tuba Ali.
Assalamu alaikum and a very good morning. So on behalf of my team, we'll be talking about a $0 investment intervention workflow that sees the delays and how we could improvement. So these are the disclosures. This is the background. So as we all know, timely initiation of radiation is integral for improving the event-free survival as well as overall survival. When we talk about radiation, and especially in pediatrics, there are various logistic concerns, especially the inter-institutional referrals. So let's talk about pediatric radiation therapy workflow. So from clinic to evaluation for GA avoidance strategies, and then simulation and CT planning, and then target volume delineation with peer review and treatment initiation. So it's just not this simple. When we talk about simulation and CT planning, we have to be mindful of the radiological discussions, the intraoperative findings, and especially when all of this data is coming from another referring institute, we have to be mindful that we're not missing anything, and this is where our intervention comes into being. So an internal institutional audit revealed that we had a median RT initiation delay of 14 days, and the reason being 2 different institutes playing part in the treatment. So there's a referring institute and then there's our treating institute. So the primary objective of this study was to look at the 2 inter-institutional workflow optimization strategy to reduce the delays. And the secondary objective was to look at the pattern and causes of delay and to introduce a low-cost intervention workflow analysis to work on it. So the main important strength of our methodology is a 8 years cohort divided between pre and post intervention with the help of an institutional intervention workflow. All the patients treated at Aga Khan Pediatric Radiation Therapy were referred from Indus Hospital, and these were the phases. So we have from 2016 to 2021, which is the pre-intervention, and then 2021 to 24, which is the post-intervention. RT initiation delay of more than 10 working days was deemed as delay. So we did comparisons. Categorical variables were compared using SPSS version 29. So this was the entire timeline. So during the treatment, all the patients were tracked for the timeline and the delays were monitored, and the AKU Indus coordination meeting was introduced. So I would want your attention over here. So all the patients who were referred for radiation at Aga Khan were standardized with a pre-meeting data compilation strategy. It was a secured shared tracker with weekly virtual meetings, and all the clinical and logistical decision making which were needed to initiate radiation on time without missing any important step was made, and actions were assigned and progress was tracked. And then RT was initiated. mind it, this was all $0, and this was all based on simple Excel sheets, and no fancy technology or no fancy thing was needed. Only the commitment and time commitment of the treating physicians was required. General practice level impact that this intervention led was for this patient, and this was a left temporalis muscle sarcoma, and on initial discussions there was no radiologically visible nodes as per the discussions, MDT discussions, but later on during our CT planning we see that there were some subcentimetric nodes which led to further investigation. And how did it impact? We had to treat the elective nodal neck, and for that we needed feeding tubes. So all of this was sorted because of this intervention, and it was sorted on time, and the patient completed the treatment on time. Similarly, in another important case in which the right chest wall Ewing sarcoma was being planned, and over here we can look on the CT planning, there was a residual nodularity with on further investigation deemed as a solitary suspicious pleural met. And this again impacted our treatment. So these are the study demographics. The pre and post intervention cohort was matched. If you talk about the results, so if you look at the simulation to treatment time delays, pre and post intervention, there's a significant decrease. So in the pre-intervention, 25 days median time was recorded, but in the post-intervention only 15. And if we talk about the number of delays, so they have decreased from 15 to 5. So we look at all the bottlenecks that could be addressed, and if you look at the possible causes, so majority of them improved post-intervention. However, during our analysis, we found out that radiological discussions and radiological scans coherence was an important issue to be addressed. So this is what the chart shows. The pre-intervention and post-intervention decrease in the causes of delays. And not just that the delays were decreased, the delay duration also decreased. The severe delays, which were like more than 20 days, decreased from 74.5% pre-intervention to 32% post-intervention. So to conclude, this $0 investment improved the radiation delays, and not just that, it also led us to an important area to think about, especially in areas where there are inter-institutional referrals, to sort of create and address those bottlenecks, especially communication labs, through these meetings. And we also identified our future roadmap, which would include centralized image integration to sort of address the radiological issues that we identified, and to further work on these low-cost digital workflow tools and sort of compile them into automated trackers for efficiency. Thank you very much.
Thank you, Dr. Tuba. We are delighted to have an international perspective. Joining us from Imperial College London to discuss PSA threshold and salvage radiotherapy outcomes in prostate cancer, please welcome Dr. Hania Irfan.
Assalamu alaikum and good morning. So, I'm Dr. Hania, a resident doctor in the UK, working in London. Today I'll be talking about the impact of PSA thresholds on salvage radiotherapy outcomes. And this will be a retrospective analysis of that. Sorry, I hope you can hear me a bit better there. So this is the landscape. After radical prostatectomy, PSA should be undetectable. When it rises, we know that microscopic disease remains either at the surgical bed or beyond. Salvage radiotherapy can cure these patients, and as the diagram shows, timing does determine that outcome. You treat early, the disease burden is low, you have a high chance of durable outcomes. You wait for imaging to show visible disease, the curative window may already have closed. This is the background. Mainly the Radicals trial, which published in The Lancet in 2020, established this current standard. Over 1,300 men were randomized to either immediate adjuvant radiotherapy or observation with early salvage, only if the PSA rose. At that time, the median PSA was 0.2 in their trial, and they found that there was no difference in biochemical progression, so early salvage was as effective as treating everyone up front and spared many men unnecessary toxicities. This established the current principle that we're now working with, so we can safely wait for early reoccurrence, but what happens when that early window is missed? Other key studies which shaped this hypothesis, so not only the Radicals trial, which I mentioned, but the SPORT trial that was published in Lancet in 2022, showed that with their median PSA of 0.35, monotherapy was insufficient. You needed to add hormones and pelvic node radiation as well to improve outcomes. Other observational trials in the in-between zone showed that delaying salvage radiotherapy when PSA was more than 0.25 was associated with increased mortality, so not just biochemical failure. The question is, where exactly is that tipping point? So this is where our retrospective study comes into place. We looked at 117 men treated with salvage radiotherapy at a single UK centre in 2016. All had received uniform treatment, so 66 Gray in 33 fractions, intensity modulated radiotherapy to only the prostate bed. 15% had also received elective nodal radiation, but crucially no hormonal therapy was used. This is in line with the Radicals trial. We divided the patients by pre-treatment PSA, so 94 having a PSA of less than 0.3, and all the rest having a PSA of more than 0.3. This is a 4-to-1 ratio, which actually does reflect real-world practice. Most men are referred early, but a significant minority continue to present late. This is where I really want you to pay attention. So the curves tell the story. You can see above that panel A is biochemical progression. The blue line is group A, so less than 0.3 PSA, and the red is group B. The curves separate within months and stay separated, and by 2 years, group B falls below 40% with a p-value less than 0.001. It's very significant. Panel B also shows overall survival. At 8 years, 86.5% were still alive in group A versus 53.9% in group B. That's a 32 percentage point difference. More than 1 in 3 of the patients in our group B had already died by the end point. But before we draw any further conclusions, it's worth noting, were these groups comparable? So this table does show baseline characteristics. Group B were our late presenters. They had more adverse pathology, understandably, higher rates of PT3 disease, 52 versus 28%, more Gleason scores above 7. So the imbalance is not surprising. Aggressive tumors do reoccur faster. So patients with high-grade disease burden are more likely to present with elevated PSA. And this is a real-world cohort, so it's not a randomized trial. However, it's still critical. The magnitude of our effect did show that pathological effects here would not explain the difference alone. We had a hazard ratio of more than 4.0, so that's larger than what Gleason upgrading or PT3 disease alone would produce in the literature. The PSA threshold does appear to capture something beyond tumor grade, likely total disease burden at the time of treatment, perhaps. It's worth noting that there are some limitations. Again, this is a retrospective single-center trial. We did not perform a multivariable analysis, as I said, for Gleason score or pathological stage, and Group B did only contain 23 patients, limiting the statistical power and the precision of our survival estimates. But consider the strengths. This is an 8-year follow-up, long enough to capture mature overall survival and not just biochemical endpoints. A uniform radiotherapy protocol without confounding from routine hormones, just like in the Radicals trial, and despite the small numbers, a highly significant p-value of less than 0.001 for biochemical progression. So most importantly, our findings do align with these major trials that we've spoken about, the Radicals, Sports, and the Tiki observational trials. So just looking again at the framework that we have here, and synthesizing our data within the trial evidence, we do propose this practical framework. So below PSA of less than 0.2, this is your radical zone. Prostate bed radiotherapy alone without hormones still achieves excellent outcomes. No need for intensification. So anything above 0.3, this is your sport zone. So this is a population where the sport trial showed benefit from adding hormones or pelvic nodal radiation, and our data suggests that monotherapy here perhaps would not be sufficient, with an 8-year survival of only 54% for these patients. Between this is the tipping point, 0.2 to 0.3, and our data suggests this is where the window begins to close and urgent referral is needed. Don't necessarily wait for imaging like PSMA PET, and treat on biochemistry. The clinical imperative is here, so if PSA is rising, just treat on the biochemistry. A few take-home messages is that the PSA above 0.3 at salvage was associated with significantly worse biochemical control as well as overall survival, and the guidelines are shifting. NCNN now defines reoccurrence at 0.1, which is half the threshold normally put through with other guidelines. Modern assays can now detect disease far earlier than when the Radicals designed trial had come about. So it still remains, refer at the first PSA rise, don't necessarily wait for a number. And practically, if PSA is approaching 0.3, don't wait for the PSMA PET scan either. If PSA is already above 0.3, consider intensification as per the SPORT trial, AT plus pelvic nodes, and the rest of our data still is hypothesis generating. It's validation in larger cohorts that's really needed. These are my key references. And again, in summary, if early, then early salvage does work, delayed salvage fails, and the threshold does determine this outcome. Thank you so much. Thank you.
Thank you, Dr. Hania. Okay, so our next scheduled speaker was Dr. Simra Qureshi from Minar Hospital. Unfortunately, she cannot make it today because her father is really sick. So we pray for his speedy recovery. And with the permission of the panel, we move on to the next presentation. Yes, okay. So we now turn our attention to critical challenge of applying international standards in our own hospital. Here to present on translating global evidence to local practice for evidence-based cervical cancer management with neoadjuvant chemotherapy from CMS Rawalpindi. Please welcome Dr. Maruna Saeed.
Thank you, ma'am. Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning, ladies and gentlemen. I am Dr. Maruna Saeed, Registrar Radiation Oncology from Combined Military Hospital, Rawalpindi, and I shall be discussing my study on the outcomes of cervical cancer patients managed at a tertiary care hospital. Before I commence with the formal presentation, I would like to thank the organizers of PSCO 26 for selecting this abstract for presentation today. I would also like to acknowledge all the patients who have participated in this study. I share no conflict of interest for this presentation, and this shall be the sequence of my presentation. In 2023, cervical cancer remained a global health issue with approximately 350,000 deaths globally. Ironically, more than 90% of cervical cancer occur in low and middle socioeconomic countries, and the disease has almost been eradicated from the Western population owing to HPV vaccination. In Pakistan, due to negligible vaccination, it still ranks as the third most frequent cancer among women. There have been significant advances in the treatment of cervical cancer, leading to an improved overall and progression-free survival. Yet, there is no unanimous approach for the radical treatment globally, with both concurrent chemoradiation and neoadjuvant chemotherapy being practiced. Situation is similar in Pakistan, and we also have a scarcity of data regarding the outcomes of different treatment approach. So we conducted a retrospective study with the aim to analyze the outcome of the treatment approach practiced at our institute, which is neoadjuvant chemotherapy followed by concurrent chemoradiation and vaginal brachytherapy. So the methodology. We included the patients of cervical cancer treated at our center between 2020 to 2024, 18 to 70 years of age with ECOG performance status 0 or 1, with an adequate renal and bone marrow function. Histologically confirmed FIGO stage 1B2 till 4A, squamous cell or adenocarcinomas, and patients with pelvic and paraaortic lymph nodes were also included. We stratified the patient by stage, nodal status, and histology. Our two endpoints were overall survival and progression-free survival at 30 months. A total of 68 patients were treated with neoadjuvant chemotherapy, carboplatin, area under the curve 2, and paclitaxel 80 mg per meter square weekly for 6 weeks, followed by concurrent chemoradiation with cisplatin 40 mg per meter square weekly for 5 weeks. 3 monthly follow-up was done for first 2 years. Standard radiotherapy technique was VMAT, delivering a total dose of 45 Gray to the primary, boosting the pelvic nodes to 55 Gray and the involved para-aortic lymph nodes to 57.5 Gray, which was followed by interstitial intracavitary brachytherapy, 28 Gray in 4 fractions, with the aim to achieve D90 of more than 85 Gray. Our overall treatment time was maintained not to exceed 56 days, and all the plans were peer-reviewed. Coming to the results. Our median age was found to be 54 years, with a range of 30 to 70 years. Most common presentation was stage 3C, accounting for 39%, followed by stage 2 at 30%, and only 2 patients had stage 1 disease. Around 90% of patients had squamous cell histology, and almost half the patients had node-positive disease. Time for the completion of treatment in 56 days was achieved in 95% of the cohort. The overall survival at 30 months was found to be 80%. Although you cannot compare different studies owing to the heterogeneity of patient population, but for the convenience of audience, I have overlaid the survival curves of Interlace trial in orange and Embrace in green with our own data in blue, with an overall survival lower than both. It is important to emphasize here that our study population had higher proportion of advanced stage with 50% node-positive patients compared to Interlace trial of 40%. There was no statistical difference in the overall survival of squam or adenocarcinomas, and patients with node-negative disease carried the best survival of 88%, followed by cohort with pelvic lymph node disease at 81%, whereas those with extrapelvic disease had a survival of 75%. This is the stage-wise distribution of survival with stage 2, 81%, stage 3, 78%, and we only had 2 patients in stage 1, and unfortunately, one of them died. 30 months progression-free survival in our cohort was 67%. I have overlaid the results of Embrace in green, 78%, Interlace in orange, 75% for reference. Again, I would re-emphasize that our population had more advanced stage disease. We only had 23 recurrences in total, out of which 31% were local and 69% distant outside the treatment field, establishing an excellent local control of 90%. Despite the neoadjuvant chemotherapy, our distant relapses remained 23%, highlighting the need to explore the option of immunotherapy. I will conclude by saying that my study established that our patient presented a higher stage of disease owing to lack of screening. Compared to the Western data, our stage-wise survival rates are similar using the modern radiotherapy and brachytherapy techniques. Despite the use of neoadjuvant chemotherapy, systemic recurrences remain undefeated, highlighting the need to explore the option of immunotherapy. Major limitation in our study is it's a single-arm, retrospective study with a limited number of patients. So a multi-centric RCT is recommended to generate high quality of evidence. I thank you all for your patient listening. Assalamu alaikum.
So we have a female predominant audience, and that is reflecting in our topics as well, because next up, presenting feasible study on plan of the day adaptive radiotherapy for cervical cancer from Anmol, Lahore. Please welcome Dr. Faika Aslam.
Assalamu alaikum everyone. I'm Dr. Faika Aslam, resident radiation oncology at Inmol Hospital, Lahore. Today I'm going to share my experience, our institute's experience on plan of the day adaptive radiotherapy on cervical cancer. The contents of this presentation are as follows. Cervical cancer remains a major global health problem, being the 4th most common cancer worldwide, with more than 85% of the cases in the low to middle income countries. The stage-wise prevalence is such that 60% cases of this disease belong to the locally advanced stage, and the standard treatment for locally advanced cervical cancer is a trimodality approach consisting of chemo-RT as well as brachytherapy. Radiotherapy for the cervical cancer is challenging with large daily changes in the pelvic anatomy. This can be appreciated in these two images. There is a major displacement of approximately 4 centimeters depending upon the bladder filling status. According to the literature, the greatest displacements were typically observed in the anterior-posterior direction, followed by superior-inferior directions. The maximal range of observed movements was 4 to 6 centimeters. So now coming to the challenges with the organ motion are reproducibility, target coverage, and changes in the bladder volume. Traditionally, we used to have 2 to 4 centimeters, those large margins, to ensure the target coverage, but that was associated with higher chances of geographical miss and larger volumes of the OAR being irradiated. Adaptive radiotherapy can be a solution to all these problems. What is adaptive radiotherapy? A notable innovation that uses image guidance to select or modify the treatment plan. It is based on the observed changes in the targets or the OARs during the course of treatment with the aim of accurately delivering the treatment to the target. There are different forms of adaptive RT. It can be online adaptive radiotherapy, plan of the day technique adaptive radiotherapy, and offline adaptive radiotherapy. In the online adaptive RT, we re-optimize the plan on the day of treatment. In the plan of the day technique, we select the best fit plan on the day of treatment before delivering the treatment. This slide shows the key clinical evidences supporting the role of adaptive RT and online plan of the day technique in the treatment of cervical cancer. All these studies were consistent with 3 findings. There was equivalent target coverage, reduction in the V95% of the volume, along with the reduction of the OARs being irradiated. Now coming to our experience, which was plan of the day adaptive radiotherapy in cervical cancer, a dosimetry and clinical feasibility study. The purpose of this study was to evaluate plan of the day technique as a strategy to manage interfractional motion, improve target coverage, and OAR reduction. Diagnosed cases of cervical cell carcinoma of cervix, squamous cell carcinoma of cervix, age less than 65 years of age, FIGO stage 1B, 3 to 4A, with an ECOG of 0 to 2 after informed consent were enrolled in the study. There were total 15 patients. The median age was 60 years. All of them were large movers. As their uterine cervix, there was a change in the uterine cervix position of more than 1 centimeter. 87% had a tumor size of more than 4 centimeter. 53% of the patients belonged to the stage 3, 26% to the stage 2, and 13 to the 4A. Only 1 patient belonged to the stage 1B3. All of them were non-metastatic, treated with concurrent chemoradiotherapy. This is the workflow of our study. As you can appreciate, that full and empty bladder scans were performed following the standardized bladder filling protocols. Afterwards, 2 plans were delineated following the EMBRACE contouring guidelines. 2 plans were made, PTV full bladder and PTV empty bladder. Afterwards, pre-treatment verification was done by the radiation oncologist and the RTTs on the day of treatment. And the best fit plan was selected from the library, and the friction was executed for the patient. In this image, you can appreciate the full bladder plan and the empty bladder plan. I want to emphasize that in our resource-limited setting, we made the empty bladder plan with incorporation of the ITV so that it can serve as the backup plan itself. Now, coming to the results of our study. Plan of the day was selected in 93% of the cases. These blue bars are showing the plan of the day, which was selected in 351 fractions among the total 375 fractions that proved the feasibility of this approach. There was better target coverage with median V 95% of the full bladder as 99%, and for the empty bladder was 93%. This can be appreciated by the blue bars, which are representing the PTV full bladder, and the orange bars that are representing the PTV empty bladder. When we analyzed the V40 of the bladder, the box and whisker plot showed us that for the full bladder plan, the V40 was 48%, and the V40 of bladder was 64% for the empty bladder plan. There was an absolute reduction of 16% with the selection of full bladder plan. When we analyzed small bowel volumes, we found a marked and consistent reduction with the full bladder plan selection as the plan of the day. As you can appreciate in this box whisker plot, that the median small bowel with full bladder was 69 centimeter cube, and with empty bladder was 181 centimeter cube. So, resulted in a median sparing of 112 centimeter cube of small bowel with the selection of the plan of the day. The V40 for rectum as an OAR resulted in a median sparing of 9% with the full bladder plan selected as the plan of the day. Weekly and 6-weekly assessment was done starting from the start of the RT. There were no grade 3 or grade 4 GU or GI toxicities recorded. There were only 26% grade 1 or grade 1 genitourinary and gastrointestinal toxicities. Only 3% were of grade 2 toxicity. So coming to the conclusion of this study, the plan of the day adaptive radiotherapy is a clinical feasible adaptive approach ensuring target coverage with significant bowel and bladder sparing with negligible geographical misses. The validation in a larger cohort is required to transition this technique into a clinical trial. Thank you so much for your patience listening.
Thank you, Dr. Faika. Moving on to breast cancer, discussing adherence to the ESTRO consensus guideline for post-mastectomy radiation therapy following immediate reconstruction from AKUH. Please welcome Dr. Sara Akhtar.
Assalamu alaikum everyone. I'm Dr. Sara Akhtar from Aga Khan University Hospital. I'm a radiation oncology resident, and today I'll be presenting my study on adherence to the ESTRO consensus guideline for post-mastectomy radiation in the immediately reconstructed breast in our setup. So as the surgical advances are progressing, we know that breast reconstruction is gaining popularity, but there has been a long-standing belief that radiation and reconstruction do not go hand in hand. The objective of our study was to assess whether, according to the ESTRO-ACROP consensus guideline, if contoured correctly, can we do radiation to the post-implant breast safely. So just an overview of the ESTRO-ACROP consensus guideline. This was published in 2019 in the Green Journal, and they describe the pattern of recurrence most at the level of skin and subcutaneous tissues in the post-mastectomy cohort, and the second most common site was the pectoral muscle. An important point to note was that the goal is to cover the tissues at risk for recurrence, not the implant itself. So the contouring must be individualized based on the type of reconstruction, the surgical details, and the original location of the tumor and risk factors. They gave a descriptive analysis of the CTV, the type of reconstruction, and the target for pre-pectoral and post-pectoral implants. These were some of the pictorial representation of the contouring guidelines. This was different for pre-pectoral and post-pectoral implants. So coming to our study was a cross-sectional study with 11 patients recruited for adjuvant radiotherapy after mastectomy and immediate implant-based reconstruction. The normal tissue dose constraints were evaluated in the VMAT and IMRT plans. The endpoints were the ipsilateral lung V17, the mean heart dose, the implant dose, and these were all analyzed via DVHs. The planning was performed on the ARIA 15 Eclipse workstation by experienced clinical medical physicists. The prescription doses were 4005 gray in 15 fractions and 4256 gray in 16 fractions to the whole breast or with additional RNI, respectively. So this is a pictorial representation of the contour in which we marked the implant as an OAR, including only the ventral surface where needed after discussion with the primary breast surgeon. So the mean implant dose was seen to be around 38.56%, the mean heart dose was 4.66 gray, and the lung V17 was 22.52%. Majority of our plans were IMRT based were VMAT based, and only 2 were planned with IMRT. Discussing the doses in details. For the mean implant, the range was noted to be 26 to 41 gray. Only one outlier was noted at 26 gray with a strong peak occurring at 39 to 40 gray. The outlier could be attributed to the patient's personal anatomy characteristics. Talking about the heart doses, the values were spanning from 2 to 7 gray, with most doses falling between 3 to 5.3 gray. In terms of V17 of the ipsilateral lung, the range was 16 to 30.2 gray, showing moderate variability. The highest dose was noted to be 30.2%, with a majority of the peak around 23 to 24%. So the conclusion from our study was simple, that with modern techniques using VMAT and IMRT, the reconstructed breast can be safely radiated, and this paves the horizon for further studies on larger cohorts to study the toxicity profiles in the implanted breast versus the non-reconstructed breast. Thank you for your patient listening.
Thank you, Dr. Sara. For our final talk, we examine toxicity profile. Presenting on ultra-hyperfractionated radiotherapy in breast cancer from Ziauddin Hospital, please welcome Dr. Rimsha Shahid.
Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning, everyone. I am Dr. Rimsha Shahid from Dr. Ziauddin University Hospital, here to present about the skin toxicity profile and dosimetric analysis of ultra-hypofractionated radiotherapy regime among breast cancer patients. Now, breast cancer ranks at the top among all other cancers in our country, and this specific registry data proves this figure to be as high as 22.2%. When it comes to treatment, multimodality treatment approach is the way to go, including surgery, systemic therapy, and radiotherapy. Here we have mentioned a few trials that have shown and historically established the role of radiotherapy, adjuvant radiotherapy, to be specific in breast cancer patients. Now, this slide here is a very important one. It highlights the importance of adaptation that fractionation regimes have shown over the years, moving from conventional fractionation to hyperfractionation, and today we are here talking about ultra-hypofractionation. Recent evidence does support ultra-hyperfractionated regimes to be non-inferior and safer, and non-inferior to the other regimes present today, but data from our population remains limited. This formed the basis of our study, and today we are here to evaluate the acute and late skin toxicity profiles associated with a 1-week ultra-hyperfractionated regime, and to evaluate the organs at risk doses associated with the same regime. Now, this was a retrospective observational study of patients receiving 26 gray in 5 fractions. The patients were treated between 2022 to 2025. All the skin toxicities were evaluated using the CTCAE version 6 criteria, and the OER doses were evaluated against the fast-forward trial. The inclusion criteria for this retrospective study was pretty simple to include the patients treated with this ultra-hyperfractionated regime during 2022 to 2025. And the patient selection criteria for this regime is taken from the fast-forward trial and listed here. All our patients were adults, males or females, having invasive breast cancer, and they had to have their primary surgery, either breast conservation surgery or mastectomy, with their axillas explored. Concurrent systemic therapy in the form of endocrine therapy or trastuzumab was permitted. The exclusion criteria was any patient requiring regional nodal irradiation, any patients needing concurrent chemotherapy, patients having metastatic disease or who've had prior radiotherapy to their chest wall or breast. Any patients with bilateral breast cancer or patients having any skin disease that was a contraindication to radiotherapy. Okay, so a little sneak peek here into the demographics of our patient. Most were in their 40s and some were as old as in their 70s or 80s. None of the patients were less than 40 years of age. Majority of the patients had breast conservation surgeries. Axillary staging was done in all of the patients, with one patient having positive nodes in their axillary staging, and they further underwent axillary dissection. And none of the patients had positive nodes on their axillary dissection. So most of the patients had ER positive, PR positive disease, and HER2 negative, and a significant number were TNBCs as well. CTVs are encompassed using the chest wall of patients or the whole breast parenchyma, and the CTV to PTV margin was 1 cm. Most of the patients were treated using 3D CRT. Patients received 5.2 gray per fraction, and three patients received a 10 gray boost in 5 fractions. Daily treatment verification using electronic portal imaging devices were done using MV imaging or KV imaging. Now, acute skin toxicity was evaluated during treatment and for 4 weeks post-treatment. The worst acute CTCAE score for our patients was grade 2, and only 1 patient had grade 2 toxicity, while 31% had grade 1 toxicity, 62% had none. Median follow-up was 19 months, and the late skin toxicity that we evaluated were ipsilateral breast or chest wall distortion, shrinkage, any edema or discomfort. Rib fractures and lung fibrosis were also looked for. 2 patients had grade 1 skin hyperpigmentation, and 2 patients had grade 1 skin induration. None of the patients had grade 2 or any other severe skin toxicity. The OER doses evaluated were again taken from the fast-forward trial. The ipsilateral lung dose, 8 gray, had to be received by less than 15% of the lung. And we had 1.5 gray was less than 30%. 7 gray for heart was less than 5%. Now, when it comes to dosimetric parameters, 31% of the patients had their constraint in ipsilateral lung achieved, while 54% and 69% patients subsequently had their heart doses in the limits. This is again a graphical representation of that same data. This table is taken from fast-forward sub-study, which showed skin toxicity profiles, acute skin toxicity profiles of their patients, with all patients, none of the patients basically received getting more than grade 2 side effects. The limitations for our study was a short follow-up duration to assess late skin toxicity and the small sample size. Although in our population subset, this regime proved to be safe and non-inferior to other fractionation regimes available for breast cancer patients. Thank you.
Thank you, Dr. Rimsha. That concludes an incredible showcase of research from our residents. Well done, guys. We stayed right on time. And I thank our esteemed panel and chairperson for their mentorship and time. We'll be collecting the scoring sheets from you now. And I request all the speakers to please come up on stage for one picture that we'll be taking with the panel. Thank you.
Good morning, everyone. I'm Dr. Iram Idris, and I will be moderating Young Oncologists' oral presentation session today. It's a great privilege to moderate this session, which is dedicated to the young oncologists. On the behalf of the organizing committee, please everyone settle down. On the behalf of the organizing committee, I warmly welcome all the distinguished guests, faculty members, and dear colleagues to this session. This session will include short oral presentation followed by brief discussion. I request all the presenters to kindly adhere to the allocated time. With great respect, I now invite our chairperson, Dr. Allah Rakha Adil, to kindly join us on stage. Now I request our esteemed panelists, Dr. Rana Atiq Anwar Khan, Dr. Tabinda, Dr. Shahid Rasool, Dr. Asghar Hussain Asghar, and Dr. Muhammad Ali Memon to join us on stage so that we can formally begin our session. Assalamu alaikum. Now I would like to invite our first presenter, Dr. Uzma Gul from Cyberknife and Tomotherapy Center, JPMC. Her topic of presentation is Precision Without Incision Cyberknife SRS in the Management of Glomus Tumors.
Assalamu alaikum and a very warm good morning to everyone. I am Uzma Gul and I am practicing as radiation oncologist and radiosurgeon at Cyberknife Department of JPMC, Karachi. I am sharing my institutional experience of treating glomus tumor on Cyberknife. Just to start with a brief introduction, paragangliomas or glomus arises from the paraganglionic cells around the jugular bulb. They are very rare with an incidence of 0.001%, yet they are locally invasive and may cause significant morbidity because of their close proximity to the critical structures. The surgery is actually the management of choice, but because of their close proximity to critical structure, the surgery is associated with substantial risk of cerebrospinal fluid leak, hearing loss, and the new cranial nerve neuropathies. These are the few cases showing the large glomus which are very close proximity to the critical structure like brainstem, internal ear, and great vessels of the neck. So making the surgery challenging, especially in the LMICs where we are having the limited surgical expertise and the exposure. Conventional radiation or SRS is increasingly favored due to its reduced morbidity, especially SRS delivers precisely high-dose radiation, minimizing damage to the adjacent nerves and brain. So the objective of my study was to evaluate the efficacy and safety of frameless Cyberknife stereotactic radiosurgery for head and neck glomus tumors with the primary endpoint of clinical improvement and the secondary endpoint of radiological response. This is a retrospective study conducted at JPMC from January 2012 till December 2023. We included all the adults of age 18 years or more having an imaging or histologically confirmed glomus jugularis, glomus tympanicum, or glomus vagale. We excluded the individuals having prior radiotherapy, carotid body paragangliomas, or having incomplete baseline imaging. Total 121 patients were retrospectively reviewed and demographic, clinical, and therapeutic data were extracted. The treatment parameters were marginal dose, number of fractions, and dose to the brainstem and cochlea. Follow-up assessment were conducted at 3 months post-treatment and then 6 to 12 monthly for next 5 years. Evaluation involved radiological assessment via contrast-enhanced MRI and the clinical assessment via patient interview and neurological examination. The response assessment criteria was clinical improvement determined by the charted symptoms reduction. The PFS is defined as the time from SRS to the radiological progression, which is defined as more than 10 or 10% increase in the volume. The secondary endpoint was radiological response, which were categorized as stable disease, progressive disease, or reduced. All patients underwent a frameless stereotactic radiosurgery using a 6 MV linear accelerator mounted on the robotic arm. The patient have a thermoplastic mask for the immobilization, and the CT scan was done at 1.2 mm slice thickness, along with an MRI of 2 mm slice thickness with no interslice gap. Target volume and OARs were delineated by radiation oncologists using Precision 3.3 software. No CTV was added to GTV. A PTV of 1 mm was added to those patients who were having some inaccuracy due to post-op changes, surgical changes. Prescription dose was delivered to 75 to 80% isodose line, covering more than 95% of the PTV. Tumor of less than 3 centimeter receive a single 15 to 16 gray fraction. Larger or adjacent lesion receive 21 to 30 gray in 3 to 5 sessions. All data were de-identified and stored in the secure and password-protected database. Normality was assessed via KMS test, and the Kaplan-Meier analysis estimated median PFS and time to clinical improvement. The two-sided p-value was less than 0.05. Here are the results. Total 121 patients were observed from 2012 till 13. They were referred from all over the Pakistan, with majority from the Sindh and Punjab, showing the population thickness in these areas. 55% were patients from the right side and 3% of the patients having bilateral glomus tumors. The majority were female, making 66% of the treated population. The most common symptom was hearing impairment, which was almost in 62% of the patient, followed by tinnitus. The most frequently involved nurse was 10th and 7th. Median prescribed marginal dose was 25 gray. Median number of fractions were 5. The brainstem dose were kept less than 12 gray to less than or equal to 1 cubic centimeter. The cochlear dose kept less than 8 gray. Median follow-up, clinical and radiological, was almost 14 months. So we divided the response as radiological and clinical. Radiologically, the reduction was seen in 74% of the patient, while 26% had stable disease. None of the patients showed progression radiologically. The clinically, almost 50% of the patient showed clinical improvement, and the 50% remained clinically stable. None of the patients showed worsening of the symptoms. So among 121 patients with evaluable clinical follow-up, 63 events of symptomatic improvement occurred. Kaplan-Meier analysis yielded a median time to clinical improvement of 36 months and a median time and a mean time of 37 months. The cumulative probability of improvement was 0.8 at 1 year, 0.6 at 2 years, and 0.07 at 3 years. So with radiological follow-up showed that am I short of time? Yes. Okay, the patient who experienced clinical improvement had a longer median follow-up up to 24 months than those who remained stable. And similarly, radiologically, the patient who showed radiological reduction were followed longer as compared to those who showed the stable disease. This large single-center study evaluated the outcomes of framed-as SRS. Finding supports the SRS as a safe, effective, and minimally invasive modality with the excellent tumor control and functional preservation. Radiological tumor control were observed in 100% of the available cases. Giving these challenges, the importance of exploring SRS as a treatment modality has become increasingly evident. There are a few evidences. This was published in Head and Neck Journal in 2020, concluding they included 101 patients. Their criteria were to have the local control, pre-treatment, deficit, and the toxicity. They followed the patient for 35 months and concluded that the local control rate was 99%. Another study for the treatment of paragangliomas with stereotactic radiosurgery support the same results. They included 61% patient. And the objective was the local control and effectiveness of the CyberKnife-based stereotactic radiosurgery. And they also concluded that the PFS was 100% with negligible toxicity during and after RT. So here I concluded that our study provides valuable insight into the utilization of SRS as a potential treatment approach for the head and neck glomus tumors with excellent local control and acceptable adverse effect profile. My references. Thank you so much.
Thank you, Dr. Uzma. Now I would like to invite our second presenter, Dr. Fatma Shokal from CyberKnife and Tomotherapy Center, JPMC. Her topic of presentation is exploring the dual burden of financial toxicity and quality of life in gastrointestinal cancer, a multicentric study analysis from Pakistan. Thank you.
Assalamu alaikum and good morning, everyone. Today, I'll be sharing a multi-center experience from Pakistan, exploring the dual burden of financial toxicity and quality of life among GI cancer patients, an issue that is highly relevant for lower middle income countries. I have nothing to disclose. So in LMIC, cancer care is largely funded by out-of-pocket payments, and cancer diagnosis not only bring physical suffering, but also leads entire family to financial crisis. So the term financial toxicity not only includes the direct cost, which includes the cost of surgery, chemo, and radiation, but also comprises of indirect cost, which involves the cost of accommodation, traveling, and loss of income. So the purpose of doing this study was a series of publication on quality of life and financial toxicity by our team. We even validated the tool which measures the financial toxicity, that is cost facet, in our own native language of Urdu for Pakistani population. Another project of financial toxicity was presented last year in PSCO, Multan, which was about the knowledge, attitude, and perception of our physicians about the financial toxicity in Pakistan. Coming to the stats, as per Globocon 2022, all the newly diagnosed cancers in LMIC are GI cancers, and in Pakistan, 1/5 of newly diagnosed malignancies are gastrointestinal cancers. And 60% of health expenditures are out of pocket, that is self-paid without any support. Based on these numbers, no studies to date have systematically evaluated financial toxicity among cancer patients in Pakistan, especially for GI cancers. So our objectives were threefold. Firstly, we assessed the prevalence of financial toxicity among patients with GI cancer. We identified the key predictors of financial toxicity and the coping mechanism of those financial toxicity. And thirdly, we evaluated the dual impact of financial toxicity on quality of life. It was a cross-sectional study conducted in an interview. It was a cross-sectional interview-based study conducted in 3 different hospitals. First was Khan University Hospital, a private fee-for-service hospital. Second was JPMC, public free-of-cost hospital. And third was Cancer Foundation, private subsidized hospital. The study conducted from May to October. 2 different data collectors conducted face-to-face interview and entered the data in REDCap after obtaining ERC from 3 different institutes. We used 3 different tools. Financial toxicity was measured using cost facet of Urdu version. The lower score showed highest financial toxicity. Quality of life was measured using EORTC C30 item tool. And socioeconomic status was measured using International Wealth Index, which not only evaluated the income of participants, but also counted the household items they had in their homes. So we included all those patients who were aged greater than 18 years with a confirmed diagnosis of GI cancer with no prior history of malignancy. Analysis was done on SPSS version 26, and qualitative and quantitative variables were documented. Coming to results, 375 patients were included in our study with a median age of 52, majority were male, and the most common diagnosis was colorectal cancers. More than 90% had no health insurance, and 1/3 patient belonged to poor socioeconomic background. Financial toxicity was alarmingly high, with nearly about 85% faced moderate to severe financial toxicity, and 1 in 4 patients faced catastrophic health expenditure, meaning they spent more than 40% of their household income in healthcare. And in this group, the poorest patients were hit the hardest. Surgery and diagnostic testing were the most financial burdensome phases of cancer care. And for financial assistance, more than 70% of the patients depended on their friends and family for support. Very few patients took help from insurance company, government, and charity. For coping strategies, 50% had significant lifestyle compromise. No, it's 2 minutes left. Okay, 50% had significant lifestyle compromise. 45% have had income generating strategies, 30% sold their valuable assets, and 25% had non-adherence to treatment. When we did multivariable analysis, financial toxicity was higher in patients who were treated in private hospital, those who were uninsured, and those who belonged to lower social tertile. Factors that lowered quality, so on assessing the quality of life with financial toxicity, it was highly linked. The quality of life was lowered in highest financial toxicity, patients who had comorbidities and unemployment. Quality of life was improved in joint family system due to support of emotional and physical support. Our strength was multi-center study, the multi-center design, large sample size, use of validated tools, and use of 3 different cost models of 3 different hospitals with a broad spectrum of finances showing from Pakistan. Our limitation was self-reported outcomes, and we only included hospitals of urban cities. So our conclusion is 85% experienced financial distress, and this burden was mainly due to out-of-pocket payments, lack of insurance, and limited financial support system. Poor patient and those treated in private hospitals are vulnerable. So financial toxicity is predictable but preventable only if we recognize it, talk about it, and act early. This is a team, and these are the co-authors of this study. Thank you so much.
Thank you, Dr. Fatma. Now, I would like to invite our third presenter, Dr. Kamal Awan from Noori Hospital, Islamabad. Her topic of presentation is Association of Serum Alpha-Fetoprotein Levels with Hepatocellular Carcinoma in accordance with the stage of the disease, a cross-sectional study from northern areas of Pakistan.
Bismillahirrahmanirrahim. I am Dr. Kamal Awan, working as a consultant traditional oncologist at Noori Hospital, Islamabad. The topic of my presentation is Association of Serum Alpha-Fetoprotein Levels with Hepatocellular Carcinoma. ठीक है pointer नहीं है इसका अच्छा है ठीक This is abstract of my presentation. As you can all see that it contains aim, methods, results, and conclusion that I will explain in later in my slides. So the objective of my study is to determine the association between alpha-fetoprotein levels and stage of the disease in patients of hepatocellular carcinoma. I specifically chosen this topic because there are very limited number of studies in Pakistan and world over on the topic of hepatocellular carcinoma. So my study design is descriptive cross-section study. That was done in the Noori Hospital, and the patients chosen were from January 2020 to December 2024. The technique was non-probability conjective sampling. Data was collected after the approval from RTMC committee and ethical review committee from Noori. Informed consent was taken from all the patients, and those registered patients that already registered are there in our study. And all the patients were evaluated in detail with their history, physical examination, and their radiological, biochemical, and hematological studies. Also, I collected the demographic data, etiology, clinical stage, serum alpha-fetoprotein levels, and childhood status of the patients. And they were categorized according to the DNM staging, and their serum alpha-fetoprotein levels were analyzed for correlation with stage and disease stage and liver functions. So as we all know that liver cancer is the 6th most common cancer worldwide, and it's the 2nd leading cause of death. And it's more common in men than in women. And the most important risk factors are the liver cirrhosis that can be caused by from the hepatitis B or C, or it can be caused by alcohol, aflatoxins, or there are also metabolic other disorders that can cause the liver damage. But so far in Pakistan, as we know that it is the most common risk factor is hepatitis-induced liver disease. The alpha-fetoprotein level is the most common serum biomarker and of the HCC so far, and in spite of its low sensitivity and specificity. This is the graphical distribution of the trending cancers in Pakistan in the 2021, and we can see that liver cancer is on the 6th number. So now I'm presenting the results of my study. The incidence of hepatocellular carcinoma is more common worldwide in men. That is the 3:1 or 4:1 ratio. And in our study, we can see that 72% of the patients, they were male, and the 28% were female. And the mean age worldwide is 62 years plus minus 10 years, and in our study, it is 61 years plus minus 10 years. In the hepatitis profile status, we can see that 90% of the patients, they were having HCV, and 8% were positive for hepatitis B virus, and 2% have no hepatitis. Now, this is the child-pugh classification of my patients, and we can see from the graph that most of them presented in the child-pugh status B. That is the 46% of the patients. Remaining 28% were in child-pugh status A and 26% in child-pugh status B, C. And the stage of the disease, previously, the studies that I have seen, they have shown the Barcelona staging system, and no one categorized them according to the TNM staging. So I'm the first one to categorize these patients according to the TNM staging. And we can see from the graph that 48% of the patients, they were having stage 3 disease, and 42 stage 4 disease. 10% only have the stage 2, and no one presented to us in stage 1 disease. Serum alpha-fetoprotein levels, I have divided them into 3 levels according to the previous studies, and less than 20 nanogram per ml is the normal level, 20 to 399 is the medium high level, and more than 400 is the extremely high level. And we can see from this graph that most of the patients presented to us in the extremely high levels of alpha-fetoproteins, that is about 48% of the patients. And now my final results, that slide showing alpha-fetoprotein levels correlation with stage of the disease. And we can see that in stage 2, the levels of alpha-fetoprotein, they are significantly lower, while in 3 and 4, in all the categories, the alpha-fetoprotein levels are high. And we can see from the graph that in stage 3 disease, the alpha-fetoprotein levels are more high in the medium and extremely high range, while in stage 4, they are more in the extremely high range. So now, coming to the discussion, hepatocellular carcinoma, as I have already told, is the most common primary liver malignancy, and it's the 6th most common cancer, and 75 to 80% of the cases worldwide of cause liver HCC hepatocellular carcinoma. And I have divided my discussion into 3 points. First is showing the global data or national data, then my study results, and then the key takeaways. So burden of HCC, we can, I already have told that it's the 6th most common cancer, 2nd cause of death, leading cause of death, and 75% to 85% of the primary liver cancers. And our study also matches the global data. So HCC is a major health challenge with very low survival rates. And then coming to the etiology, and I already told that in Pakistan, most common etiology is the hepatitis virus, and more is HCV is more common, while HBV is less common. So in our study, that is same with the concurrent with the Pakistani data, that 90% is HCV positive patients are there, and HCV is a dominant risk factor. Gender distribution, as regarding globally in Pakistani studies and in our study, is the same, that men is more common and than the females. Then coming to the childpugh status, and in our study, I have shown that mostly 46% patients presented to us in childpugh status B. And so majority had impaired liver function at the time of presentation. And the stage, as globally, 70% of the patients have the stage intermediate and advanced stages. And in Pakistan, they are present in late stage. But in our study, we also proved that our patients also present in the late stages. But this is the thing that worldwide, the patients are not presenting due to better screening methods. They are presenting in early stages. But we are still in, like low-income countries like Pakistan, it's still in the late stage presentation. So my last slide, conclusion. Serum alpha-fetoprotein level show a positive association with advancing HCC with significantly higher values in stage 3 and 4 disease. But considerable overlap exists between stage 3 and 4, indicating that alpha-fetoprotein levels alone may not be reliable distinguishing between the stages. And so combination of alpha-fetoprotein levels with clinical staging and childpugh classification, it improves the prognostic assessment. And there's urgent need of screening in our Pakistani patients with long-standing history of HCV, so that we can also pick out patients in early stages, and we can offer them the radical treatments. So my last slide is, only in the darkness can you see the stars. Thank you.
Thank you, Dr. Kaval. Now I would like to invite our next presenter, Dr. Syed Mohsin Raza from Shaukat Khanam, Lahore. He will present on induction chemotherapy versus upfront surgery in locally advanced lung cancer, outcome of 200 patients over 5 years.
In the name of Almighty, who is the most gracious and the most merciful, I am Dr. Mohsin Raza, Fellow, Radiation Oncology in the department at Shaukat Khanam Memorial Hospital and Research Center. First of all, I am grateful to the society for giving me the opportunity to present my work. I will be presenting on the clinical outcomes of induction chemotherapy versus the upfront surgery in locally advanced lung cancer. Here is the brief outline of my presentation. I will be discussing the study objectives, methodology, results, and final conclusion. The choice between the surgical intervention and chemotherapy is central in oncology. While chemotherapy provides a systemic reach, whereas surgery provides the localized control. The core objectives of my study: the first one, disease-free survival; the second, the overall survival; and the third one is the efficacy benchmark to look at the toxicity and outcomes between the two approaches. Here's the methodology. Our study was of 199 patients. The retrospective review, it was a retrospective review of 199 patients, including the stage 3 and 4A localized lung cancer. First was the surgery arm, in which surgery was done upfront, and the second was the induction chemotherapy arm. 95% confidence, the statistical analysis was 95% confidence interval, ensuring that the results were not due to the random variance. Here is the study overview, the design. Neoadjuvant chemotherapy arm, there were 112 patients, whereas in the upfront surgery, there were 89 patients. The functional endpoints include the mucositis, dysphagia, and the PEG dependency. Whereas the survival outcomes, there were the overall survival and the progression-free survival. When talking about the patient demographics, and this induction chemotherapy group has a younger population as compared to the surgical group. This was a selection bias, that the T stage in the induction chemotherapy group were higher as compared to the surgery group, whereas the performance status and the risk factors were very well balanced between the two groups. Here you can see that the chemotherapy group has 112 patients, and there are locally advanced patients in chemotherapy group, whereas in the surgery, there were early stage patients. This was a selection bias. When talking about the disease-free interval, which was the most critical metric, we have seen that there was a 10 months overall survival in the chemotherapy group, whereas when talking about the surgery group, there was a 2.27 months additional benefit in this group. This revealed that the surgery demonstrated a significantly longer median DFS as compared to the chemotherapy. Here is the Kaplan-Meier curve of disease-free survival between these two modalities. You can see that the green line indicating the surgery group is more as compared to the chemotherapy group. When talking about the second metric, which was the overall survival, the surgery group has 49.16 mean overall survival, whereas the chemotherapy group was 45.49 months. This revealed that surgery demonstrated a significantly longer mean overall survival as compared to the chemotherapy. This is the Kaplan-Meier curve of the surgery group. It revealed that the mean overall survival is more in the surgery as compared to the chemotherapy. If we talk about the functional outcomes, the mucositis, dysphagia, and the PEG dependency, both of the groups were, the patients in both of the groups were experiencing the same toxicities. In other words, the patients in the surgery group were having the same toxicity at the advantage of the survival outcomes. There were few limitations of the study, as it was a retrospective design. There was selection bias, but in conclusion, I will say that the surgery group was, the DFS as well as the OS in surgery were more as compared to the chemotherapy. That's all. Thank you so very much.
Thank you, Dr. Mohsin. Now, I would like to invite our next presenter, Dr. Mohammad Atif Mansha from Dow University Hospital, Karachi. He will present on empty bladder pelvic radiotherapy using magnetic resonance integrated linear accelerator.
Bismillahirrahmanirrahim and Assalamu alaikum to everyone. I'm Dr. Atif Mansha and I'm very thankful to the scientific committee for giving me this opportunity to present my abstract on the empty bladder protocol. In pelvic radiation, the standard practice is to comfortably fill the bladder in order to stabilize the pelvic anatomy and to displace the organs at risk. But we have seen that the patients have inconsistent bladder filling and they undergo discomfort and urgency, which leads to prolonged treatment times and setup times. And on MR Clinic, the workflow is quite lengthy. First, there is real-time imaging. We do real-time contouring and real-time plan optimization, so it takes a lot of time on MR. So there is further risk that the bladder gets distended. There is increased couch time on MR Clinic, and the patient feels uncomfortable. And in the worst case scenario, the patient voids on the couch. And we have seen this happening many times on MR Clinic because of increased treatment time. So we conducted an audit at our institute, and we realized that the main problem was filling of the bladder. There was change in the bladder volume, which led to target displacement, and the target displacement led to the increased contouring time, increased optimization times, which led to further increase in the treatment time, and the patients were not able to hold their urine throughout this time. These are the MRI pictures of a distended bladder and the empty bladder of the same patient. Within the duration of one fraction, the bladder fills so much. And also our patients, they are not that much educated and they are unable to apprehend our instructions, and also some of them have cultural and religious beliefs, so it is quite difficult to make them understand what we want to say. So we looked for possible solutions. We came up with this evidence, and this evidence shows that with the empty bladder treatments, we can also achieve the same PTV coverage and same organ at risk tolerance doses. So we hypothesized that with empty bladder protocol, we can minimize bladder-related uncertainties, enhance patient cooperation, and ensure stable dose delivery. The objective of our study was to evaluate whether empty bladder protocol was adequate in ensuring PTV coverage and OR sparing, and the secondary objectives were patient comfort and treatment time. It was a prospective institutional study, and we included 20 patients, 10 patients with empty bladder, and further 10 patients with full bladder. And all the patients included in the study must have any pelvic malignancy, and age should be more than 18 years, and all the patients who had any contraindication to MRI, they were excluded. All the patients were given this patient experience and comfort questionnaire. This was developed by our radiographers and was approved by the institutional review board. This is basically a 5-point questionnaire. And conventional dosimetric constraints were used in empty bladder patients. These are the plans with the empty bladder and the filling bladder. Now moving to results, the average treatment time with the empty bladder was reduced by 10 minutes. Initially it was 48 minutes and then to 35 minutes. There were reduction in treatment interruptions of around 35%, and the comfort level as per our scoring criteria, it improved from 2.7 to 4, and the incidence of on-couch voiding was 0. Dosimetrically, PTV were adequately covered in all the patients, and OR doses were within tolerances in all the patients. So we conclude that with empty bladder protocol, the patients feel comfortable, it simplifies their workflow, they are compliant, and we also ensure the excellent target coverage and OR sparing. This is our team, my hospital. Thank you.
Thank you, Dr. Adif. Now I would like to invite our next presenter, Dr. Wajiha Anjum from Inmol Hospital, Lahore. She will present on pathological complete response following neoadjuvant chemotherapy alone.
Thank you, Dr. Iram. Assalamu alaikum and good morning, everyone. I am Dr. Wajiha Anjum, consultant clinical oncologist at Inmol Cancer Hospital, and I am going to present the PCR rates in triple-negative breast cancer following neoadjuvant chemotherapy alone, a perspective from a resource-limited setting, a single institutional experience. Triple-negative breast cancer accounts for 15% of all breast cancer, and here is higher incidence in the African American and Hispanic women, and we know that 15 to 20% are BRCA positive, and these are sensitive to the chemotherapy and improve overall survival and as well as DFS. So talking about the triple-negative breast cancer, it's not a single disease. There are multiple subtypes of the TNBC, and 10 to 15% of TNBC are rich have immune cell process, and these are the category which responds well with immunotherapy. So is all the TNBC are the same? No. This is a heterogeneous disease, and different subtypes have likely to have a different Achilles heel. So these are the chemotherapeutic agents we offer in the clinics for triple-negative breast cancer. And according to the literature, the conventional chemotherapy has a PCR rate of 30 to 40%, while the addition of the pembrolizumab immunotherapy have improved the PCR rates. These are the landmark trials for conventional chemotherapy showing the PCR rates between 25 to 30%, while the addition of the carboplatin to the conventional chemotherapy has further improved the PCR rates. And here the keynote 522, which is the standard of care for the triple-negative breast cancer, and addition of this pembro result in absolute benefit of the PCR around 14%. The rationale behind this study that is there in the limited real-world data from the resource-limited setting on the outcome of the triple-negative breast cancer treated with the chemotherapy alone, restricted access to the immunotherapy in low and middle income regions, and there is need to evaluate institutional outcome and feasibility of the standard neoadjuvant chemotherapy regimens in such settings. So the study was done to assess the association between the clinical pathological variables with the PCR and to analyze the DFS as well as overall survival. This was conducted at Involve Hospital. It is a retrospective observation study, and around 73 patients with non-metastatic triple-negative breast cancer who were candidate for the neoadjuvant chemotherapy were enrolled, and data were collected from the previous record. We all know the PCR is a complete response with no residual disease after neoadjuvant therapy in tumor as well as in the nodal nodes. This was the inclusion and exclusion criteria, and these are the demographic variables which were being studied. And the primary endpoint was the PCR and the pathological complete response, and the secondary outcome was the DFS and overall survival. And following the descriptive analysis were done to see the results. And talking about the data, there were around 7,800 newly registered cancer patients enrolled in the year 2022, and out of which around 800 were the breast cancer patients, and of triple-negative breast cancer were 100 cases, accounting for the 13% of the total breast cancer. And out of these 100 cases, 27 were the metastatic and the 73 were the non-metastatic breast cancer. So further demographic study was done being on these 73 patients. So seeing this graph, this is the age distribution, but the alarming thing that we had most of the young population, like below 40 years. Locally advanced disease was the most common one, and 32% were the stage 3B. Similarly, the laterality, talking about laterality, left side was more common. And out of 73, 53 patients received the neoadjuvant chemotherapy, while the 20 patients had upfront surgery before registering the enroll. So after neoadjuvant chemotherapy, 53% underwent MRM because we had locally advanced tumors, so MRM was being done. And grade 3 was the most common grade. And similarly, 75% patient had more than 14 Ki67. These were the chemotherapy regimes being offered to the patient, and 43% received the conventional chemo, 36% received carboplatin and the acetaxane, and 19% had dose-dense chemotherapy, as there was younger population and the good performance status. And the PCR rate was 41%, and non-PCR were 58%. And seeing the PCR with respect to the chemotherapy, so there was a good result. As expected, that with the conventional chemotherapy, we achieved a 34% PCR. With the addition of the carboplatin, it was markedly raised to 57%, and with those, it was about 40%. And there was better PCR in the early stages. And similarly, the grade 3 had the 64% PCR, as the chemosensitive grade 3 are the most chemosensitive, and hence the 64% PCR seen in the Ki67 higher group. Talking about the DFS, it was improved in the straight line in the PCR group, the 36 months follow-up. There were a few drops, while talking about the overall survival, it was also straight line and higher, and the non-PCR had the steeper and earlier drops. So in this real-world retrospective study from the low-middle-income country setting, standard neoadjuvant chemotherapy without pembrolizumab achieved a PCR rate of 41%, comparable to the historical pre-immunotherapy data. Addition of the carboplatin significantly improved PCR 57% compared to the anthracycline taxane-based regime, confirming the chemosensitive nature of the triple-negative breast cancer. Earlier clinical stage was strongly associated with a higher PCR, while the predominance of the stage 3 disease reflect delayed presentation in this resource-limiting setting. High-grade, high Ki67 demonstrated better PCR consistent with a high chemotherapy sensitivity in this biological subset. Patient achieving PCR had a superior DFS as well as overall survival. So optimized chemotherapy, especially carboplatin, can achieve meaningful responses and improve DFS in the TNBC group, even in the absence of the immunotherapy, making it a practical strategy in the resource-limiting setting. Thank you so much. This was all about my study, but on this forum, I would like to share that in this ESMO 2025, this was a paper which was presented for a low and middle income country, that the low dose pembrolizumab can achieve the PCR. So based on this, I invite you all to enroll for this study, and this will be planned for observational study, and as TNBC has a high prevalence in Pakistan, younger age, advanced stages, Pembro with chemo improve PCR, the low dose Pembro may retain efficacy while improving the affordability. So anyone who wants to enroll can email me on this address by the February 28, 2026, and we will discuss the possibilities and everything regarding this. So we should start our own studies regarding this immunotherapy. Thank you so much.
Thank you, Dr. Wajia. Now I would like to invite Dr. Sakina Hashmani from AEMC Karachi. She will present on challenges in implementing image-guided radiotherapy in a resource-limited setup.
क्या करते हैं इसको बड़ा कर दूं प्रेजेंटर भी चाहिए नहीं चाहिए प्रेजेंटर नहीं मैं खुद चेंज करूँगी ना ये इससे का आप नेविगेशन बड़ा चाहिए नहीं ठीक है इस पे ये तो बस इससे हो जाएगी ना जी आगे से इससे
Assalamu alaikum and very good morning to you all. First of all, I would like to say thanks to the scientific committee of PSCO to give me this opportunity to present my work at this forum. Today, I'll be presenting our institutional audit that reflects the real-world challenges in modern radiation oncology. This is our center where I work, and this is the machine where we have treated the patients. As you all know that image-guided radiotherapy is an essential component of modern radiation oncology, allowing improved treatment accuracy, reduced margins, and better target localization. These are some of the CBCT images which I have taken from our system for the review. But, there is a gap that always exists between guidelines, recommendation, and real-world feasibility. As in resource-limited setting, challenges in consistent implementation of IGRT is often faced challenges, that is infrastructure, workflow, and workforce constraints. And in our setup, we observed that variability in IGRT implementation in spite of keen interest to comply on it. Therefore, we conducted this audit to evaluate the clinical, technical, and the logistical barriers in IGRT implementation, and also to assess the workflow impact, and also to explore the improvement strategies that is facing in IGRT implementations. This is a retrospective 6 months institutional audit that was conducted from March till August 2025, and we reviewed 35 patients who has been treated with 3D CRT using CBCT-based IGRT with curative intent. The data were collected from treatment logs, CBCT records, QA and the maintenance log, and the treatment schedules. In addition to this, semi-structured feedback questionnaire was completed by RTTs to evaluate the hidden barriers in IGRT implementations. The parameters that we have evaluated in this audit were IGRT adherence, reasons for missed or delayed IGRT, equipment performance, staff training adequacy, and the workflow impact. The overall IGRT adherence, that is IGRT performed of scheduled sessions, was observed as 72%, and the missed or delayed sessions were noted in 28%. The one thing I need to clarify here that in any scheduled CBCT, if one session is missed during the whole treatment, we consider this as a single missed session. The barriers that we have evaluated in this audit to implement IGRT were high patient load and limited staff, that is 38%. Patient-related factors like discomfort and prolonged immobilization, 21%. Limited staff training, 20%. Technical issues, 12%. And the machine-related interruptions was 9%. The clinical impact of these identified barriers have a significant clinical impact on daily clinical practice, that staff shortages lead to time pressure, the patient discomfort affecting the compliance, the training gaps causing protocol variation, and the technical issues disrupting workflow causing reduced reliability of imaging sessions. The workflow alone has a huge impact on IGRT, as it increases the time of 8 to 10 minutes per patient, and these cumulative delays significantly affect in a high volume department, as it reduced patient throughput and increased staff fatigue and risk of deprioritizing imaging under strict scheduling constraints. Feedback from RTTs highlighted the need for periodic refresher training, simplification of site-specific protocols to improve efficiency, emphasis on balance between precision and feasibility for sustainable long-term practice. The adaptive strategies in order to comply IGRT, the adaptive strategies we should adopt for protocol-based CBCT imaging, preventive maintenance planning, and focused staff training that strengthens the protocol adherence. I would like to conclude my presentation here with this note that IGRT in a resource-limited setting should be adapted, not abandoned, to achieve accuracy without compromising feasibility. Thank you.
Thank you, Dr. Sakina. Now, I am the last presenter. I am Dr. Iram Idris from NCCI Hospital, Karachi. I will present my study on acute side effect of VMAT in head and neck cancer patient. So these are the content of my study. This slide briefly illustrates the evolution from 3D to IMRT and then to VMAT. IMRT uses multiple fixed beam with dynamic MLCs movement, while on the other hand, we may deliver radiation through continuous gantry rotation with simultaneously variable dose rate and the gantry speed. So why I choose VMAT? Because head and neck cancer are anatomically complex. They require high dose radiation while close proximity to the critical structure. Although IMRT improve dose conformity, but it is associated with the acute toxicity and with prolonged treatment time. VMAT, it is the advanced form of IMRT that allows highly conformal dose radiation, better OER sparing, and the shorter delivery time. These are some studies that demonstrate that VMAT provide comparable and improved plan quality with shorter delivery time and better OER sparing as compared to 3D and IMRT. So the study objective of my study is to evaluate the acute toxicity associated with the VMAT while specifically focusing on radiation-induced mucositis, radiation-induced dermatitis, and radiation-induced dysphagia. And the secondary objective to evaluate, to grade these toxicities, and the most important thing, to generate institutional data on VMAT. So this was a descriptive study conducted at NCCI Hospital, Karachi from the period of May 23 to May 24. And the study population include all head and neck cancer patients on VMAT. We include male and female patient ages between 18 to 70 years of age, histologically proven diagnosis, and the patient treated on VMAT. And the exclusion criteria were previous or concurrent malignancy, palliative cases, radiation cases, and those who decline informed consents. So all patients treated on, all patients of head and neck cancer treated with VMAT, we evaluated after 6 weeks post-RT, and we evaluate acute toxicity, oral mucositis, dysphagia, and dermatitis on CTCA criteria version 5.0. For quantitative variable, we use mean plus minus standard deviation, and for qualitative, we calculated frequencies and percentages. So total 92 patients were included in this study, and known probability sampling technique was used, and the sample calculator was WHO calculator. So we choose VMAT-SIP technique with the following dose prescription. For gross disease, we use 2.66 gray per fraction in 25 fraction, which is equivalent to 70 gray. And for intermediate risk area, we use 2.35 gray in 25 fraction, which is equivalent to 60 gray. And for the low risk area, we use 2.14 gray in 25 fraction, which is equivalent to 54 gray. Concurrent with chemotherapy when indicated. So this is the treatment flow after acquiring images. The process begins from contouring, target localization, and OERs contouring, followed by dose optimization. And then subsequently VMAT planning is performed, and the plan quality is evaluated using DVH analysis. And then finally the treatment delivery with high image guidance. All this streamlined workflow ensure the patient safety and the treatment accuracy. So these are the patient and the disease-related characteristics. Mostly were male in this study, and the most common site is oral cavity, followed by larynx, and the most clinical stage was clinically T4A and 2B, and the most common pathological stage was PT4A and 2 EPN1. These are results that show that dermatitis is the most common toxicity, and followed by oral mucositis and then dysphagia. And this slide shows that acute radiation mucositis according to grade. So grade 2 was the most common toxicity, followed by grade 1, and subsequently then grade 3 and 4. And this is acute radiation dermatitis severity according to grade, which is grade 1 is the most common among all. And grade 1 and grade 2 dysphagia are almost same, followed by grade 3. So conclusion of my study is we may deliver high precision radiotherapy with excellent target coverage, high efficacy and precision, and grades were mostly of grade 1 and 2, which was easily manageable with supportive care. So VMAT is well tolerated with minimal interruption, and it enables efficient delivery with reduced treatment time. So my take-home message is VMAT combine precision, efficiency, and patient safety, making it superior modality of choice for head and neck cancer patients and with manageable acute toxicity. Thank you for listening. Now I would like to invite all the presenters to come on stage for group photo. Now our 19th session is Women for Oncology, and this is open for all. It will be start on sharply 11:20 a.m.
Okay. Detail record. Let's see.
वीडियो पूरी पूरी
Assalamu alaikum to all of you. Please be seated so we can start our 19th session of this conference. 19th and last session, inshallah. So I welcome you all to the most exciting session of this conference, that is Women for Oncology. वजूद ज़न से है तस्वीर कायनात में रंग, इसी के साथ से है ज़िंदगी का सोज़े दरूं. With this, I want to invite my panel of judges plus my team of Women for Oncology, Dr. Humaira Mahmood, who is currently serving as the Director of Atomic Energy Hospital Noori, is a highly distinguished consultant clinical and radiation oncologist. She is widely recognized as a pioneer in the field. Having been the first female oncologist of Pakistan, she is the Senior Vice President of Pakistan Society of Clinical Oncology and a key member of the scientific team of ONCO 2026. She is a mentor to many students, including me, serving across the world. Thank you, ma'am. My next panelist is Dr. Tabinda Sadaf. Ma'am, please come on the stage, working as an Associate Medical Director in Oncology, Shaukat Khanam Hospital. She joined in 2009 as fellow and then as consultant in 2014 after FRCR. My next panelist is Dr. Sadia Rizvi. She is a senior oncologist working at Kiran, now with more than 20 years of experience. I would like to invite Dr. Kuratulan Hashmi on the stage. She is a FCPS clinical oncologist, certified palliative care specialist, certified in medical teaching, working as principal medical officer in Minar Cancer Hospital, Multan. Dr. Kuratulan. Now invite Dr. Rahila Mahmood, who holds an MSc in nuclear medicine and is FCPS qualified in radiation oncology. She has a strong clinical and academic background with a special interest in brachytherapy and pediatric oncology. She has been actively involved in advanced radiation techniques and contributes significantly to multidisciplinary cancer care. I invite Dr. Maria Tariq. She is a consultant radiation oncologist at Aga Khan University Hospital. She is a founder of Kipro and has a special interest in leadership. My next panelist is Dr. Fatma Shaukat. She is a radiation oncologist working at CyberKnife and Tomotherapy at JPMC, and she is a founder of TEF JSMU chapter. My next panelist is Dr. Iram Idris. She is a RMO working at NCCI Hospital. And Dr. Zainab Rafat, she's a resident at NCCI under Dr. Azhar Rashid. She both have worked very hard for this conference day and night, and you all have witnessed their hard work during this conference. Dr. Sadia from the INMOL is not with us. She is also the part of our Women for Oncology team. Okay. So I invite my first speaker. She is Dr. Hira Yusuf Khan, is a consultant med-onc at Leeds Cancer Center, UK, where she is specialized in breast oncology and immunotherapy. Alongside her clinical expertise, she plays a pivotal role in medical education as the regional lead for oncology training, supporting the development of future oncologists through both formal and informal mentoring. Please welcome Dr. Hira Yusuf Khan. She will be talking about the empowering of women in oncology.
Assalamu alaikum, everyone. I am truly, truly excited to be here and honored that I have been invited to give in this talk. So my name is Dr. Hira Yusuf Khan. I'm a consultant medical oncologist in Leeds. Apart from being a consultant, I do lots of mentorship, education programs, and currently I'm also fighting for equity rights for Asian oncology trainees. This is where I work, Bexley Wing, and the riverside is where I live. It's a very beautiful river, Stanley Ferry in Wakefield. So going forward, everyone knows the founder of our nation, Quaid-e-Azam Muhammad Ali Jinnah. He used to say that there are two great powers in this world. One is the sword and the other is the pen. And there is great of rivalry in competition between the two. But there is a third power greater than both, and that is our women. So the more time I spend in the field, the more time I spend in the oncology, I see what a strong force we are. And with regards to the issues women we are facing globally or in Pakistan, you name them and we are facing them. Be it inequality, be it security issues, be it fighting for specialty, or be it fighting for leadership or research roles. The question is how we will make our voices heard. Starting with Rufeda al-Aslamia, who is the pioneer of Path of Compassion in nursing history. She built the first health center near the Masjid al-Nabawi in Medina during the time of Prophet Muhammad sallallahu alaihi wasallam. Her distinction as Islam's inaugural female surgeon and nurse is universally acknowledged. Women who changed the history. For Florence Nightingale, you all are very well aware of. Marie Curie. Going forward, women who changed the history of Pakistan. Fatma Ali Jinnah, Rana Liaquat Khan, Benazir Bhutto. You all know them really well. Talking about a little bit about England, women in NHS, there are 77% women in the NHS workforce. 47% of them they are doing senior manager roles, 53% of doctors are in training, 54% are GPs, and 37% are consultants. In my hospital, we have a clinical lead and a clinical director who is a woman, and oncology educational lead who is a woman, and that's me. So challenges faced by women, social barriers, I will talk about this in a little bit of detail, gender discrimination, primary caregivers, double shift, they are not offered flexible working hours, personal barriers, ambition gap, invisible work, political savvy. Organizational barriers are unequal mentorship, lack of role models, trailing spouse, unconscious bias. I just love this slide. The likability paradox. Why is it so difficult for female leaders to be both liked and respected? A woman is bossy, a man has leadership skills. A woman is aggressive, a man is assertive. A woman is nagging, a man is persistent. A woman is stubborn, a man is determined. A woman is hysterical, a man is passionate. A woman is pushy, a man is ambitious. One thing which I would like to add is a woman is emotional and a man is practical. So, talking about the very first slide, choice of speciality. Often the choice of a speciality when you want to go ahead is influenced by external factors, including societal pressures and family pressures, especially in the cultural setting of Pakistan with the joint family system. The family members plays a pivotal role in individuals' career decision. It is influenced by gender roles. Males mostly opt for surgery, females opt for obs and gynae. We need to make sure that these choices remains autonomous, reflecting personal passion and the country's healthcare needs. Work-life balance. Every woman sitting here in this audience, how to strike a balance between family and profession. Is it really possible? We need to create healthy boundaries. Prioritize your tasks and time, do what you love, and balance is possible. However, I haven't achieved this yet. The unspoken burden of sharing pregnancy news in the workplace, the frowns you experience from the HR, the frowns you experience from your colleagues. Talking about maternity leaves. Now, I had a chat with few women since last 3 days while I was here, and I was shocked that the maternity leaves are not approved in few sectors. However, Aga Khan does provide 12 to 16 weeks of maternity leaves as compared to 52 weeks of maternity leave provided by NHS in the UK, which is paid. This is a significant global disparity in support for working mothers. Short leave periods often place undue stress on women, especially when they are expected to return to work while still recovering physically and adjusting emotionally to motherhood. Fear of job insecurity: if you will not come back, we will replace you. Workplace intolerance: if you are absent because you're having nausea, vomiting, hyperemesis, that is frowned upon, and this is discrimination. Mental and emotional strain: balancing recovery, childcare, and professional expectations can be overwhelming without adequate support. So we need to think about revising our maternity leave policies, like the NHS 52 weeks policy. Plus, I want to add, there should be paternity leave for 2 weeks for males as well, so they can support the family. Key ways to support working mothers: flexible hours, remote working options, and compressed work weeks. Cultural barriers: in male-dominated society, the majority of women in Pakistan have no right to make decisions and choices even regarding their marriages. It's a different talk about choice of a specialty then. Leadership roles: Pakistani female doctors face gender discrimination, unfortunately, that negatively impacts their workplace performance and has proven to be a hindrance to them taking up leadership roles. This patriarchal mindset of society and lack of basic facilities in the hospital for working mothers are just a few of the factors that compel women to leave their careers. A very strong slide: Hillary Clinton said, "Too many women in too many countries speak the same language, which is the language of silence." If they are leaders, do we give women leaders a hard time? I wish someone had told me about the challenges of being a woman in medicine. Many people, but especially women, feel fraudulent when they are praised for their accomplishments, and I felt like that yesterday. Despite strides in women's presentation in powerful roles, a surprising number of people across the world still don't trust women to lead effectively. And these biases are deep-seated and may be difficult to challenge. Unfortunately, there is workplace sexual harassment all over the world, especially in academic oncology. Depression, anxiety, and stress in young female doctors is associated with high sexual harassment scores. It's underreported. We need to raise our voices. We can't raise our voices because of fear of losing job and social stigma. Victims often face blame or reputational damage. Although Pakistan has laws like Protection Against Harassment of Women at the Workplace, Act implementation remains inconsistent. A food of thought: I was thinking last night, had a chat with few Pakistani oncologists, that top leadership remains male-led. There is no evidence of a woman serving as a PSCO president or a CPSB president. Now, I can talk and go on and on about issues. What are the solutions? Thankfully, Pakistan Society of Clinical Oncology has provided us this platform for young oncologists and for women in oncology, where we can speak up, where we can share ideas, and where we can come up with the solutions. Second thing is that we know these are the issues. Where and whom to signpost these issues? Who is going to revise the policy for maternity leaves? What are our safeguarding rights? How can we support our working mothers? How can we provide them childcare services? How can we support our young doctors? We should have mentorship schemes. Leadership and research opportunities should be equal for both male and female. Lastly, education, education, education. Empower yourselves so you can empower your patients and empower the society. A silver lining, hope at the end of the tunnel. These all beautiful women, exemplary, commendable efforts in teaching, education, leadership opportunities. Dr. Humaira Mahmood, Dr. Nazli Hussain, VC of the University of Health Sciences, Dr. Tavinder Sadaf, Dr. Sadia Saqib, Dr. Kurtlan Bada, Dr. Shaza Rahman, lots of women I met, beautiful women in ONCO 2026, Dr. Kurtlan Hashmi, Dr. Sandis Yahya, Dr. Maria Tariq, and Dr. Fatma Shaukat. They are doing a great job in leadership and education. In my last slide, this is a picture from PSCO. I would just like to conclude this session by giving a big round of applause to every woman in this audience, many people who are watching me online, and every woman who will see this video later. Despite the challenges you have faced, you have shined. You are resilient, you are powerful, and you are an inspiration. I am proud of you, and we are proud of you. Love yourself, because no one else will. No one else will. Thank you.
Thank you so much, Dr. Hira. It was a wonderful talk, and I'll safely say that, inshallah, in the coming years, it will be changed, and more women you will see, inshallah, on the leadership positions. Because in the last FCPS exam, there were 10 female candidates on this side of the table, and there were 10 male examiners on this side of the table, along with only 2 women, me and Dr. Humaira. So we can already witnessing this change in oncology field. Now we are moving forward to our free paper session, and my first, I'll call Dr. Fahmi Abdullah. She's working as a clinical oncologist at Atomic Energy Medical Hospital, Minar, Multan. I'll request all the presenters to be brief and short and complete their presentation within 7 minutes, because we have to wrap up early, because many of them have to catch up the flight. Thank you. Thank you so much.
Assalamu alaikum. I'm Dr. Fahmi Abdullah. I'm working as clinical oncologist at Atomic Energy Cancer Hospital, Minar, Multan. First of all, I'm thankful to the organizers for giving me the opportunity to present my work here. Today, I'll be discussing palliative quad-shot radiation therapy combined with low-dose systemic treatment in locally advanced head and neck cancer. There is no conflict of interest. Head and neck carcinoma is one of the common cancers in Pakistan, and most of the patients present towards us in locally advanced stage. Reason being, there is lack of healthcare facilities, and secondly, patients which present to us, if I talk about my area in Multan, in South Punjab, they do not have enough awareness. And when anything appears like a lesion in the mouth or ulcer or neck nodule, they usually keep on ignoring the symptoms because they don't have enough resources to come to the hospital, and these present in locally advanced stage. And concurrent chemoradiation becomes standard of care in this stage. But again, these patients don't have enough resources, and they belong to lower socioeconomic class, and performance status is compromised, and nutritional status is also compromised, so they have ECOG 2 or 3 mostly. So palliative idea behind this work was palliative quad-shot radiation therapy, which we usually use for palliation, like for bleeding or symptom control. We have used this regimen to see the responses, mainly objective responses. And there are some reference studies. A phase 2 clinical trial was conducted, and it showed objective response rate, 2 complete response, and 14 partial response with this palliative quad-shot radiotherapy 2 days regimen. Again, as these patients present with poor performance status, they do not tolerate definitive 6 weeks concurrent chemoradiotherapy, we used afatinib, and there are some studies with this systemic therapy, there are objective responses, and almost 16% of the patients in this reference study show objective response rate with afatinib. So in our part of the world, with poor performance status, ECOG 2 to 3, not very resourceful to stay in the hospital for 6 weeks and tolerate concurrent chemoradiotherapy definitive, we need for less toxic yet effective treatment strategies, and we combined cord-short radiation therapy with capecitabine afatinib, and aim was to improve tolerability and quality of life. Again, but main objective with this palliative, so-called palliative cord-short regimen was to see the efficacy and toxicity with this regimen, basically. So this study was conducted at Atomic Energy Cancer Hospital, Minar Multan, and it was descriptive case series. 47 patients were included, and it was non-probability purposive sampling, and all patients were biopsy-proven head and neck squamous cell carcinomas with poor performance status, ECOG 2 and 3, which were unable to tolerate concurrent chemoradiation therapy, and most of the patients were of oral cavity followed by oropharynx, hypopharynx, and larynx, and we excluded NPC as it is distinct entity, and we gave capecitabine 500 milligram per oral BID along with afatinib 40 milligram per oral OD with cord-short radiotherapy. It was 14 gray per cycle, 3.5 gray in 4 fractions, and it was repeated after a month, and maximum of 3 cycles were given, and response was assessed before each cycle, and toxicity, we saw hematological, mucosal, and skin toxicity, and the capecitabine and afatinib was continued until significant toxicity developed. Now coming towards the results, most of the patients were male, 52%, and most of the patients belonged to 51 to 60 years of age group. And when we saw the results, almost 57% of the patients showed partial response with this cord-short radiotherapy along with systemic therapy, and there were complete responses were also seen in 90%, and these were the patients which had poorly differentiated carcinomas, T3 disease, so they developed even complete response. If I talk about toxicity, treatment was generally well tolerated, and there was no grade 3 or 4 toxicities, only grade 1 and 2, and most of the patients, they presented with mucositis and followed by the dermatitis, and there was also diarrhea, but it was grade 1 and 2, and we just switched afatinib after that, stopped. We have to restrict the dose of this afatinib. To conclude, low-dose capecitabine, that is 500 milligram per oral BID, and afatinib with cord-short radiotherapy is feasible in these patients which have poor performance status and unable to tolerate definitive concurrent chemoradiotherapy, and it demonstrates encouraging tumor response, and toxicity profile was acceptable, and is a potential treatment option for these patients in resource-limited settings. But further, we have to validate this finding with large samples, and comparative study obviously is needed, only cord-short with or without systemic therapy, and we are planning to get PFS and OS estimate after this. And in the end, I want to acknowledge the whole Department of Oncology of Minar Cancer Hospital, especially our director and HOD. These are my references, and thank you so much.
Thank you so much. Now I'll call Dr. Fajar Rafi Ranja. She's a second-year clinical and radiation oncology fellow at Shaukat Khana Memorial Cancer Hospital. Her clinical and research interests include neuro, breast, and GU cancers. Dr. Fajar Rafi Ranja.
Thank you so much. Assalamu alaikum and a very good morning to all of you. My name is Dr. Fajar Rafi Ranja, and I'm currently working as a fellow in clinical and radiation oncology department of Shaukat Khana Hospital, Lahore. So the topic that I'm presenting today is the outcomes of medulloblastoma treated with VMAT-based CSI. So starting with some introduction of CSI and medulloblastoma, why CSI matters in medulloblastoma? We know that CSI plays a vital role in managing central nervous system malignancies, especially those with high propensity for leptomeningeal spread, such as medulloblastoma and primitive neuroectodermal tumors. So CSI is the cornerstone of their treatment. It is required for both pediatric and adult medulloblastoma. We all know that traditionally CSI was done with 3D conformal radiotherapy, and it was technically challenging and very toxic. So let's dive into the pitfalls of conventional CSI. It was a problem because opposed lateral brain fields were used, posterior spinal fields were used, which led to major toxicities, including field junction and hot and cold spots, dose inhomogeneity, and high-dose acute hematological toxicity. It was a very difficult setup, and especially in children. The real challenge was the length of CSI. We know that CSI has a length of 45 to 80 centimeters. One isocenter technique is not possible, and multi-isocenters are required. So now coming towards the evolution of radiation from 3D conformal to VMAT, which is for CSI. Now one would wonder why VMAT is used for CSI. As we can see from the diagram as well, with photons treated with 3D, we can see that there was extreme inhomogeneity and hot and cold spots, while the patients who were treated with VMAT, it was a continuous arc delivery with improved homogeneity, junctional feathering, and organ-at-risk sparing. There were reduced setup uncertainties and treatment time. It has been increasingly used in worldwide, and low-middle income country data is sparse. So we conducted this study at our hospital. We know that pediatric CSI is very resource intensive, and our center has state-of-the-art Linacs with pediatric anesthesia support. So we aim to report feasibility and outcomes of VMAT CSI. So it was a retrospective analysis conducted at our hospital from a time period of 2018 to 2024. 113 consecutive medulloblastoma patients were included, which included adult and pediatric population both. The study was IRB approved. So the objectives were to evaluate dosimetry quality, conformity index, homogeneity index, and PTV coverage, organs at risk doses, acute toxicity, and early disease outcome. So the flow was majority of the patients were treated in supine position. That accounted for 79% of the patients. Immobilization was done with 5-point thermoplastic mask and a vacuum bag. CT was acquired from vertex to sacrum with 3 mm slice thickness, and it was then fused with MRI. CTV included the whole brain and spine, cribriform plate, meninges, pituitary fossa, subarachnoid space with lateral extensions to the nerve roots. It was then given a 5 mm margin to form PTV. The organs at risk that were contoured were not limited to eyes and lenses, but it also had parotid glands, lungs, kidneys, liver, heart, and gonads. So then the contours were handed over to the physics team for VMAT planning technique. They used 2 to 3 isocentric technique with 2 centimeters overlap, auto feathering, and 6 ME photons were used. 2 full arcs per isocenter and simultaneous optimization. Planning goal was to have more than 95% of the PTV receiving 100% of the dose. So patients were then followed up on the weekly basis for evaluation and toxicity assessment. Monitoring was done in the radiation department for acute toxicities related to dermatological, gastrointestinal, hematological, and neurological. Weekly CBC was also performed to look at treatment-related myelosuppression, and a comprehensive acute toxicity assessment was done at 6 weeks post-radiation as well. The tool that we used was CTC-AE version 5 to assess for clinical evaluation and toxicity. They also had long-term follow-up with pediatric oncology for late effects of CSI, including endocrine, neurocognitive, and growth-related outcomes. So patient characteristics were the median age was 12 years, which ranged from 4 to 37 years of age. Mostly were pediatric population, which accounted for 67% of the patients. 69 were of high-risk disease, and the rest were for average risk. GTR was in 38% of the patients, and CSF positivity was in 14% of the patients. So these are the treatment details. The CSI dose ranged from 23.4 gray to 36 gray, with tumor bed boost from 54 to 55.8 gray. Concurrent chemotherapy was in 66.7% of the patients, and RT alone in 33% of the patients. So these are the dosimetric results. Mean PTV coverage was 94%. Conformity index was 1.02. Homogeneity index was 0.1, and majority were treated with more than or 3 isocenters. Now these are the organs at risk. We can see that mean kidney dose and mean heart dose was approximately 6.5 grays. Mean lung dose was 7.2 gray, and liver with V19 was minimal. Acute toxicity was mostly grade 1 and 2, which included esophagitis, bone marrow suppression, and nausea vomiting. There was no unexpected toxicity in these patients. So the early outcomes were median follow-up of 15 months, and 2-year disease-free survival was of 76%. So moving on to the key takeaways, we know that VMAT CSI is feasible, safe, and dosimetrically robust. Acute toxicity is acceptable, and early disease control is encouraging. So it is a strong option for low-middle income country settings. Limitations of the study was that it was a retrospective nature, short follow-up. There's limited late toxicity data, and molecular subgrouping was not available. Thank you so much.
Our next speaker is Dr. Rahila Mahmood. She's a working radiation oncologist at Atomic Energy Medical Center, Karachi.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Today I'm going to present the data of high-dose rate brachytherapy in cervical cancer, a decade of experience from a tertiary care center. As we all know that cervical cancer is a major world health problem in worldwide, especially in developing countries. And basically it's a preventable disease, but still it is one of the leading cause of cancer death because of limited primary prevention, that is lack of HPV vaccination and pap smearing program. The standard of curative treatment for cervical cancer is surgery and radiation therapy. As a rule, surgery is limited for very early lesion, while the radiation therapy is the curative treatment for advanced disease. In cervical cancer, brachytherapy has a pivotal role as it delivers very high radiation dose to the target and simultaneously sparing the organ at risk. The objective of my study is to assess local control, disease-free survival, and overall survival in cervical cancer patients treated with high-dose rate brachytherapy in a tertiary care center, and also analyze the pattern of failure, that is local, regional, and distant recurrence following treatment. Its institutional review board approval was obtained before commencement of this study, and it's a single-arm retrospective chart review was conducted on consecutive locally advanced cancer of cervical cancer presented in our department, and we treated with combination of chemoradiation and brachytherapy between the period of January 2014 to December 2023. All patients had been, metastatic workup had been done with CT scan, chest, abdomen, and pelvis, and then MR pelvis used for local staging. Patients were planned for EBRT of 45 to 50.4 gray, and for brachytherapy, we use 7 gray of 4 fraction using remote afterloading system and Iridium-192 source. And systemic therapy consisted of weekly cisplatin 40 milligram per meter square with a median of 5 cycles. Some patients receive also induction chemotherapy of 6 to 9 cycles in case of large tumor and long waiting time to start EBRT. At the end of EBRT, we advise pelvic MR scan to evaluate the tumor response and also to better define the target volume during brachytherapy, because in brachytherapy, we do a CT scan after every insertion and delineate the volume of HRCTV, IRCTV, and organ at risk according to GC store recommendations. During treatment, we follow the patient weekly, and after completion of treatment, we do follow-up every 3 months for 2 years, then every 6 months for further 3 years, and then annual follow-up. This is our patient data. We have evaluated around 558 patients, and the median age at diagnosis is 38 years. The median follow-up duration is 5.2 years, and mostly we observe the commonest histologies is squamous cell carcinoma followed by adenocarcinoma. The most common stage is FIGO stage 2B, and the most common histology is grade 2. The clinical outcome were recorded. The endpoint of my study is disease-free survival, overall survival, and local control. Disease-free survival is the time from treatment completion to either local or metastatic recurrence. Overall survival is the absence of death from any cause. Local recurrence is absence of any recurrent or progressive disease within the irradiated area. The result where we analyzed is that out of 558 patients in my study, mostly patients had distant recurrence in 22% of the cases, while local failure noticed in 18% of the cases. The disease-free survival, which we observed is 2-year disease-free survival is 71%, while overall survival is 76%. The 5-year disease-free survival is 58%, while overall survival is 62%. The standard overall treatment time in cervical cancer is 7 to 8 weeks, and with increasing every day, we lose the local control. In my study, mostly patients have completed their treatment within 8 weeks of a start of the treatment. The strong dose and local control correlation is noticed between HRCTV dose and the local control. And in my study, 81% of the patients receive HRCTV, 90% is more than 85 gray. There is some limitations. It's a retrospective study, may introduce biases, and some inaccuracies noticed in record maintenance between treatment date and gaps. Chemotherapy detail record were missing, and despite we follow the guideline, but still the contouring of HRCTV on CT images had inter-observer variability, so the dose calculation is variable. Difference in follow-up duration among patients may have influenced reported survival and local control. We face some challenges for implementation of brachy. There is inadequate funding for equipment and maintenance, infrastructure issues related to exchange of radioactive source, which may lead to treatment gaps between brachytherapy treatment. Also, there is lack of timely patient referrals and the shortage of trained health professionals to deliver the treatment. Thank you so much.
Thank you, Dr. Ayla, for well completing before time. Now I'll call Dr. Malia Ahmed. She's a postgraduate trainee at SIUT Karachi. Dr. Malia.
Assalamu alaikum everybody, I'm Dr. Malia from SIUT. I'm a postgraduate trainee there. Today I'll be presenting my pilot study on the impact, the impact of structured pre-simulation counseling on psychological outcomes in breast cancer patients undergoing radiotherapy. This study mainly focuses on a very simple intervention, counseling, which is a very critical but often neglected point in our radiotherapy practice. Imagine stepping into a radiotherapy room for the very first time, surrounded by mask, machine, and uncertainty. For many of our breast cancer patients, this moment carries a significant hidden burden of depression, anxiety, and stress, and it is precisely this idea that led us to conduct this study. As radiation oncologists, we often spend significant time in planning, contouring, and delivering precise treatment. But if we reflect on our clinical practice, this question arises that how many of us routinely counsel patients before radiotherapy? Yet, structured counseling before simulation is rarely practiced, and this carries a significant weight in patients in their journey. So, we asked a simple question. If we counsel patients before simulation, can we improve their overall experience? So we conducted this pilot study in which 20 female breast cancer patients were enrolled. After informed consent, patient completed DAS-21 questionnaire to assess baseline depression, anxiety, and stress levels. A structured counseling session was then provided by a physician and a radiation therapist, which covered the radiotherapy process, possible side effect, and also their queries was answered. Subsequently, patient underwent CT simulation, and a post-simulation DAS-21 questionnaire was re-administered to compare the results. Here you can see the DAS-21 questionnaire. It includes 21 very simple questions which capture three key elements: depression, anxiety, and stress. We included female with histologically confirmed breast cancer. Those who were scheduled for radiotherapy were above 18 years of age and were able to provide informed consent. Patients with any psychiatric illness, psychotropic medications which were unable to comprehend counseling or questionnaires were excluded from the study, and also palliative patients were not included in this study. So coming to the results, a paired sample t-test was conducted to compare pre- and post-intervention scores for depression, anxiety, and stress. And the results we observed were there was a significant reduction after the intervention in all three domains. The largest difference was seen in stress, followed by depression and anxiety. Talking about the results in detail now, depression showed the mean difference of 3.5 post-intervention with a p-value of 0.015, which means that it showed significant reduction. Anxiety levels also dropped significantly with a mean difference of 2.3 and a p-value of 0.02. Stress shows the most striking response with a mean difference of almost 6 points. So we also compared our results with a control group that included 20 patients, and no counseling was provided in the control group cohort. There was no significant reduction observed in the control group patients. So a simple low-cost intervention like counseling can result in significant reduction in depression, anxiety, and stress levels. It also builds trust and confidence and can easily be integrated into our routine oncology care. The limitations of this study included small sample size. It was a single-centered study. There was no long follow-up. And the DES-21 is a self-reported questionnaire, so there's always a risk of bias. Results may not be generalized to all cancer populations. I'd like to acknowledge my mentors and colleagues at SIUT. Thank you.
Now I'll call Dr. Abida Sheikh. She's an FCPS qualified radiation oncologist with over 10 years of experience in comprehensive cancer care. She completed her fellowship in clinical and radiation oncology at Shaukat Khanum Memorial Cancer Hospital and currently serving as a radiation oncologist at Kuwait Cancer Control Center. Dr. Abida Sheikh.
Bismillahirrahmanirrahim. Assalamu alaikum. Today I will be discussing about the acute GI toxicities in locally advanced rectal cancer patients undergoing neoadjuvant chemoradiation. So as we all know that acute GI toxicity remains a prevalent complication in the patients undergoing pelvic radiation therapy, and the small bowel is particularly vulnerable, often acting as a dose-limiting OAR. So the objective of this study was to examine the relationship between the radiation dose received by the small bowel and the incidence of acute lower GI toxicities and identify key dose parameters to pinpoint specific dose parameters that demonstrate potential in reducing the risk of treatment-induced toxicity, thereby enhancing the patient care. So total 100 patients were diagnosed with locally advanced rectal cancers who received long course of radiation therapy with IMRT techniques were enrolled in this group. And after delineation, the peritoneal cavity was delineated in accordance with the established RTOG guidelines. Volumes of the peritoneal cavity receiving 5, 10, 15, 20, and 40 and 45 gray were respectively analyzed. So grades of acute GI toxicities were assessed on a weekly basis throughout the treatment period, and toxicity grading was adhered to the common terminology criteria for adverse events. CTCAE version 5 was used for which defines grade 3 toxicity as diarrhea more than 7 stools per day, incontinence, severe abdominal cramping, need for hospitalization, and limitation of self-care. These are the published data for volume of the small bowel receiving different doses. So a notable 12% of the patients experienced grade 3 or higher small bowel toxicity within the study cohort, which is comparable to the systematic review, which showed wide ranges of grade 3 toxicity ranging from 5 to 25% in patients undergoing IMRT techniques. A highly significant dose-volume relationship was observed between the irradiation of the peritoneal space and the occurrence of acute small bowel toxicity. The analysis revealed that the greatest sensitivity for predicting toxicity was specifically associated with volume receiving 5 gray. So patients with V5 greater than 300 cc had 3.2-fold higher odds of developing grade 3 toxicity. Dose volume histogram analysis of peritoneal space volume accurately predicts grade 3 or higher acute small bowel toxicity. This study strongly suggests that peritoneal space V5 greater than 300 cc demonstrates a high correlation with incidence of grade 3 toxicity. This is consistent with the published IMRT studies, which shows that low dose bath V5 to V15 is more strongly associated with GI toxicity. So a focus on minimizing the volume of peritoneal space 5 gray receiving less than 300 cc should be there, and potentially decreases the incidence and severity of acute small bowel toxicity. Tailored treatment plans based on individual patient anatomy and risk factors for GI toxicity should be there. By quantifying the relationship between small bowel irradiation and acute GI toxicity, this research provides valuable insights for advancing rectal care cancer techniques. Thank you.
Thank you so much, Dr. Abita. Now I'll call Dr. Kuratulan Hashmi. She is working as a principal medical officer at Minar Cancer Hospital, Multan. Dr. Kuratulan.
Assalamu alaikum. I'm Dr. Kuratulan Hashmi and I'm working as clinical oncologist in Minar Cancer Hospital, Multan. I'm very thankful to Pakistan Society of Clinical Oncology, ONCO 2026, that they have given me an opportunity to to present my very simple study, physical therapy and rehabilitation to improve quality of life in breast cancer survivors in Women for Oncology 2026 for the very first time. This is simple study, but I think this study is having high empathy and high emotional intelligence. So there is no conflict of interest. The contents of my study: introduction, background, rationale, objectives, methodology, assessment tools, key results, and conclusion. As we all know that breast cancer is the most common malignancy worldwide, including Pakistan, and according to Globocon 2022, 31.2% females, they were diagnosed with breast cancer. And we also know that there are multiple treatments for breast cancer like surgery, chemotherapy, radiotherapy, and so on. But we will focus on surgical morbidity because surgery is the mainstay of treatment. It is actually giving the overall survival benefit for the breast cancer survivors. So the background of my study is that post-surgical breast cancer patients, they commonly experience pain, reduced mobility, muscle weakness, poor quality of life, having problems in poor range of movements around shoulder joint, pain around chest wall, around armpits, increase in the sensitivity of pain, many problems like that. So physical therapy, it offers a non-pharmacological approach to manage pain and functional limitations after breast cancer treatment in these patients. To evaluate the effect of a 16-week structured physical therapy program on pain reduction and quality of life in breast cancer patients, this study was conducted after approval from the ethical committee and my director permission. A cross-sectional study of 60 post-surgical breast cancer patients was conducted in Minar Cancer Hospital from September 2024 till July 2025. It was 16 weeks plan and it was under the supervision of a doctor of physiotherapy, that is DPT, specialist doctor with her team, oncologists, nurses, and the patient attendants. You can see here the frequencies, categories, number of patients, and the selection of the patients. The inclusion criteria was that all post-surgical breast cancer patients, they were selected for the study after their consent. And there was the age of about 23 to 65 years, median age was there. And the exclusion criteria was stage 4 breast cancer, male breast cancer, and the patients who were on neoadjuvant chemotherapy for breast cancer treatment. So the plan was that we divided our physical therapy plan in 3 weeks, in 3 phases, actually, phase 1, 2, and 3. And there were some exercises plus transcutaneous electrical nerve stimulation, which was done by DPT specialist along with her team. And this plan was that we divided 3 phases, phase 1 from week 1 to week 6, then phase 2 from week 7 to 11, and then from 12 to 15, phase 3. In phase 1, simple exercises, as you can see here, shoulder blade stretches, chest wall stretches, side bending. They were advised by the physical DPT doctor along with nurse. And TENS, that is, it was given in the sessions, about 3 to 5 sessions per week on daily basis for 10 to 15 times, along with walk time that was 10 to 15. So in second week, we added resistant exercises and simpler exercises, and the time of the exercise was increased from 10 to 15 minutes to 20 to 25 minutes. And along with this, 10 sessions, they were reduced. That is transcutaneous electrical nerve stimulation. As we know that it worked by release of endorphins and by reducing the pain at the site of the pain-like arms, chest wall. There are 4 sites, A, B, and C. These are the most commonly placed tense sites where the pain was felt in majority of the patients. So I put it here. And in phase 3, these exercises plus ascending stairs according to patient convenience, according to patient age, according to patient morbidities, it was advised by the doctor, along with brisk walking for about 40 minutes, and 10 sessions they were reduced only on occasional basis on patient demand. That was 15 weeks plan, and then at 16 weeks, we got assessment of the patients. Assessment tools were universal visual analog scale, as you can see here. That was for the measurement of pain, and quality of life, it was measured by Karnofsky performance scale. And SPS version 25 was used, repeat measure ANOVA was used, and the key results for pain, mean VAS score decreased by 54.2%, showing significant pain reduction after physical therapy, and it has significant p-value less than 0.001, as you can see here from graph as well. And the mean KPS scores improved by 36.8%, indicating enhanced functional status and quality of life, significant p-value with less than 0.001, as you can see from these graphs as well. So quality of life and pain both were managed in those patients. Structured physical therapy significantly reduces pain and improves quality of life, highlighting the need for standardized rehabilitation services. So we should consider all these things in our mind as well, that with pharmacological treatment, non-pharmacological aid should be there for the patients, especially for rehabilitation services and for cancer survivors. Thank you so much, and in the end, I'm dedicating this presentation, this small talk, this simple but very EI, high score EI study to one of my mentor, Dr. Arif Jamshed. ढूंढोगे अगर मुल्कों मुल्कों मिलने के नहीं नायाब हैं हम. Thank you so much.
So our last speaker is Dr. Rafia Toor. She has done MSc in Radiation Medical Oncology from PIAS and MSc in Nutrition from AIOU Islamabad. She is retired from AACH Noori Islamabad, and she is presently working as charity basis at Hamza Welfare Hospital, Pind Bhagwal, Simli Dam Road, Islamabad. If I can give one example of a lifelong learner, I can give an example of Dr. Rafia Toor. Please welcome Dr. Rafia Toor.
Assalamu alaikum, and thank you very much, Dr. Kurathalan, for such a nice words. Today, I'm really honored, humbled, and happy to be here, even as a retired radiation oncologist. And so today, my presentation is, other than the radiation toxicities and chemotherapy toxicities. It is about the financial toxicities, and I'm happy 2 of our clinical oncologists has presented. One of Dr. Fatma has presented the financial toxicity, and yesterday a young oncologist, Hiba Siddiqui, she also presented the case about the maintenance dose and financial toxicity. So it's a good change that oncologists are realizing that financial toxicity is very important. So I have no conflict of interest, as Dr. Kurutal and Heather is Dr. Kurutal and said that I am all doing this work on charity basis, voluntarily, and no funding at all. So the financial burden of cancer, it's a leading cause of death. Cancer is a leading cause of death worldwide, and 75% of all patients are treated by Shaukat Khanum receiving financial assistance. When I was preparing this presentation and my first slide, this was the first paper of 2012 by Dr. Arif Jamshed, and it's difficult for me to say that it's late, Dr. Arif Jamshed. It was the first paper on financial toxicity, presenting that 75% of patients treated by Shaukat Khanum, they received financial assistance. So it means that this thing was very important in the start of cancer treatment. So objective financial toxicity among cancer patients in lower middle income ranges from 17% to 93%. You can see that. Next is that this financial toxicity of cancer care in low middle income countries, it's a systemic review and meta-analysis in which 13 countries of Asia has been included. And they were saying that surgery, radiotherapy, chemotherapy, and if you can see the palliative care, it's having a lot higher burden on the patient in dollars. So there's another paper of financial toxicity of cancer treatment and its impact on quality of life in tertiary care hospital. It's from KPK area, in which you can see that 71% was affecting the patient's family life, their assets. Some of them were losing job, and only 10% was satisfied with the treatment of cancer. So the cancer expenses in Pakistan, especially the Atomic Energy Cancer Hospital, although they are providing, the PAEC hospital providing the services of surgery, if you can compare the private and public sector, still this burden is a lot. So it's all in dollars, and I am holding the other side of my role as a dietary role in cancer prevention and reducing financial toxicity as one end, because the cancer, 30 to 40% of these cancers can be prevented by dietary changes. So these habits of taking excessive meat, frequent intake of processed food, and high consumption of refined carbohydrates, these can lead to colorectal, breast, and gastric cancer. So it's a tug of war between the treating team of oncologists, surgeons, and physicians, and the other side is by the patients suffering from cancer, and they're losing sometimes their chemotherapy schedules because of their financial impact. Sometimes they don't be able to get the required investigation done, and their stages upgrades just because of this reason. So I am representing another option of this tug of war in lower middle income country. Why not preventive substance come into play by adding fruits and vegetables before developing cancer? So there is one of this paper, that role of nutrition in cancer prevention, the effect of dietary pattern of bioactive compounds and metabolic pathways. It's been proven that by diet we can reduce the incidence of breast cancer, and the paradigm shift is there. The pyramid of food is changing on, and it's preventing the DNA damage, the chronic inflammation as well. So eating more fruits in teen years may help stave off breast cancer. So eating pink this is the presentation in a Harvard Gazette in May 2016, and a study was conducted on 90,000 female girls, teen girls, and they evaluate that all those teen girls which were eating 3 or more than 3 fruits per day, the incidence of breast cancer reduced 27% in that cohort. So I conducted a pilot study of dietary changes on breast cancer awareness in Islamabad. Breast Cancer Initiative is working in Sohan, which is the area near Islamabad, and it consists of 160,000 population. And they were doing the awareness program there, because as we all know that 9 in 1 female can be suffering from breast cancer in their lifetime. So my target was to address the young girls of 9th, 10th, and first year and second year schools to change their dietary habits if I can. So first of all, I went there and I asked the administration that if I can address these girls, and being the ex-clinical oncologist from Noori, this was given a very good start to me, that I was given the opportunity and they allowed me to address this. So first of all, I filled the questionnaires from these young girls that what are they eating. They were having 50 rupees per day on their as a pocket money. So I've asked them that I've estimated that around 35 to 45 rupees, 3 fruits, guava, banana, and fruiter or quinoa or orange, you can say, it's estimated around 35 to 45 rupees. So I've asked them that is it possible that would you like to change your diet, because I've explained them that this is a rising incidence of breast cancer. Okay, fine. So thank you very much for telling me that. So I've advised them, and they really, in my second visit, when I've asked them that did they change their attitude. So as you can see that 53%, although I know they cannot afford, but this 22% can afford, but as they did not have the knowledge, it's improved their dietary habits, and they have started eating fruits, 3 fruits per day. And this was, if you can see that the estimate is $920 per year. So the expenditure and prevention can work in hand. So this was the competition which I arranged there, and they responded with this beautiful pictures. And my take-home messages for all young females sitting in front of me, that please eat 3 fruits per day. It will prevent breast cancer, at least 27% of the population. Thank you very much. Eat pink for breast cancer prevention, and thank you.
Thank you so much, Dr. Rafia. And now I move forward to a surprise panel discussion. And that is more than one role, women balancing, oncology and life. So the panel is open for discussion for, our junior residents are sitting here, our junior consultants are sitting here who may be struggling with some sort of challenges in their life, balancing work and balancing, children, kids, khana pakana or baki sari cheezein at home. And you may see these leading women who are sitting on the stage as a role model, but they all must have faced difficulties in their life, and they reach here. So हर किसी की ज़िंदगी में कोई एक ना एक वक्त आता है which is difficult, but then you have to overcome that time. Like me, for the last 4 days, I don't know about my children. Where are they? And because of the support of my husband, of my mother, and obviously when my late father was there, he was there to support me, to continue my work. And I'm here because of them. So we all need some kind of a support. Dr. Fahim and Dr. Humaira is one of the best examples in front of us, in which both of them have a leading role, not in the oncology. And we can all think about them, that how can they reach to that place, balancing mashallah, they have raised a beautiful children who are sitting there in the hall as well. So I would like to ask Dr. Humaira, I have asked Dr. Fahim as well, maybe he must join us. I asked Dr. Asghar as well to join us on the stage along with Dr. Sadia Rizvi, who is sitting here. So these are the examples in front of us, and they must have, you know, Dr. Sadia must have, maybe she has supported more than Dr. Asghar to then Dr. Sadia more supported Dr. Asghar, because he is now on the leading, on a leading stage, and she is there to bring the child up and to the brought up of their kids. So the forum is now open for the discussion. Dr. Humaira, first of all, you can start. How you have balanced work and kids, bacche, khana pakana, saas, nande. आपके लिए जो डिफिकल्टीज रही, जो चैलेंजेस रहे. माइक मिल जाएगा प्लीज.
Okay. Thank you, Dr. Kuratulain Badr. This is for the first time that we are sitting in the forum of Women for Oncology, Pakistan. Before this, I have been attending seminars organized by ESMO Women for Oncology, Asia Women for Oncology, and IAEA Women for Oncology. And I really was thinking that why not Women for Oncology Pakistan? So thanks to Dr. Azhar for taking this initiative and getting the idea materialized. Actually, Women for Oncology is not something political. It is under the auspices of Pakistan Society of Clinical Oncology, and it's aimed at helping women cope with the issues that were highlighted by Dr. Hira in her presentation, helping them cope with the difficulties they are facing in their struggle during their career, and also at the same time helping them how they can keep balance between their work place and their life. And at the same time, we were aiming to help our young residents who are struggling to, who are just in the beginning of their careers, so as to help them in their academics as well. So Badr has asked me about my experience. Of course, the credit goes to my strong family support. Dr. Fahim is sitting here. I have been through all the stages. Of course, my children were very small at one time, and I used to take them to all the conferences or seminars wherever I was going. And it was all because of Dr. Fahim. He was always there to support. He has never asked me to do cooking or to do anything like that. Similarly, my in-laws were very supportive. My mother was always there to take care of my children. And this is what I have learned, and I am looking at my younger colleagues, my residents who are working with me, that unless and until you have got family support, you have got support in your workplace, you cannot cope with what you are trying to achieve. Because it's really important, as one of the issues that was highlighted by Dr. Hira with regard to maternity leaves. We are very generous in that. As government has allowed 3 months maternity leave, so we are always allowing this to our students as well. And similarly, there are other problems. We are there to help them out, but still, I think the most important thing is support from family as well as your workplace.
Yes, I agree with you.
Otherwise, it's not possible.
So leadership like you always, support, who support the females, that is very good. Dr. Fahim sir, please आप बताएं थोड़ा सा कि आपको क्या challenges हुए Dr. Humaira के working होने से? Sir, please आ जाओ.
बैठे बैठे आपने छेड़खानी शुरू कर दी हमारे घर में.
ये ऑफ नहीं हो रहा.
देखें, जो सबसे इम्पॉर्टेंट चीज़ होती है ना इंसान की ज़िंदगी में, वो आपकी अपनी फैमिली होती है। और फैमिली अलोन जो है वो ये नहीं हो सकता कि हस्बैंड और वाइफ डॉक्टर हों और दोनों एक प्रोफेशन में हों, वो एक दूसरे को अगर सपोर्ट ना करें, आप नहीं रह सकते। तो जो एक लाइफ का बैलेंस है ना, वो सबसे इम्पॉर्टेंट चीज़ होती है। गिव एंड टेक के बगैर गुजारा नहीं होता। यू हैव टू सेक्रीफाइस। आपने अपनी ख्वाहिशात को किसी को कम करना होता है, अपनी प्रायोरिटीज़ आपने डिफ़ाइन करनी है। तो जहाँ तक हमारा ताल्लुक़ है, मेरा ख्याल है कि मैं खुशनसीब हूँ कि मुझे इस तरह का जो है वो एक माहौल मिला कि वाइफ मुझे इस तरह की मिली जो ऑलवेज बीन सपोर्टिव। और जो उससे इम्पॉर्टेंट चीज़ होती है वो होती है कि आप एक टिपिकल जो एक हस्बैंड एटीट्यूड, जो यहाँ पे एक डॉक्टर साहिबा जो विलायत से तशरीफ़ लाई हैं फरमा रही थी, वर्क प्लेस इनहांस वो हरासमेंट या घर की हरासमेंट, मेरे ख्याल इज़ ऑल नॉनसेंस। आपको अपना दिल बड़ा करना पड़ता है, आपको अपने ट्रेडिशनल जो चीज़ें उनसे बाहर निकलना होता है, एंड यू हैव टू फाइट योर सेल्फ इन ऑल एस्पेक्ट्स जब आपके घर की बात आती है। और ये भी कहना कि जी आप पढ़ाएं भी, खाने भी पकाएं, नौकरियां भी करें, मरीज़ों को भी देखें, तो एक लिमिट होती है इंसान की। अगर आप सारा कुछ ही एक्सपेक्ट कर रहे हैं एक टिपिकल एक ट्रेडिशनल वाइफ बना के, तो मेरा नहीं ख्याल है कि आप कोई जस्टिफिकेशन दे रहे हैं या कोई जस्टिफाई कर रहे हैं इन चीज़ों को। उसके लिए आपको अपने कान बंद रखने होते हैं और आंखें खुली रखनी होती हैं। अगर आप कोई अच्छी ज़िंदगी गुजारना चाहते हैं, आजकल के कल्चर में, ये खाली पाकिस्तानी या इंडियन कल्चर नहीं है कि जी घर के अंदर ये होता है तो सास आ गई तो बहू आ गई। ये अमेरिका में भी होता है और इंग्लैंड में भी होता है, वहाँ भी सासें होती हैं, लेकिन हमारी सासों को ज़्यादा बदनाम किया जाता है। ऐसा नहीं है। मेरी जो सास हैं, उर्दू में मैं इसलिए बोल रहा हूँ ताकि अच्छी तरह समझ में आ जाए, उन्होंने मेरे दोनों बच्चों को बड़ा किया, रेस किया उनको। बच्चे जो अभी माशाल्लाह एक रेजिडेंसी कर रहा है, वो भी रेडिएशन ऑन्कोलॉजी में कर रहा है। बेटी मेरी अभी 4th ईयर के अंदर आ गई है, वो भी पढ़ रहे हैं, हम भी पढ़ रहे हैं। तो जो इन्होंने कुर्रतुल ऐन ने छेड़खानी करने की कोशिश की, वो नाकाम हो गई। तो एक चीज़ अपने जहन में रखें, आपने अगर एक अच्छी ज़िंदगी गुजारनी है और आप दोनों सेम प्रोफेशन को बिलोंग करते हैं, सेक्रीफाइस एक ऐसी चीज़ है, लाइफ का बैलेंस उस वक्त होता है, आपने अपनी बहुत सारी ख्वाहिशात को कम करना होता है और दूसरे की ख्वाहिशात को अहमियत देनी होती है। और दूसरी तरफ से भी अगर ये एटीट्यूड हो तो ये कामयाबी का राज है, अल्लाह पाक की तरफ से मदद आती है। तो इसको आप, ये जो यंग जनरेशन है ना, अभी इनको नहीं पता, ये जेन ज़ी है ना, अभी एक और भी आ गया, अल्फ़ा आ गया। हम लोग हैं बेबी बूमर्स। और बेबी बूमर्स क्या थे? बेबी बूमर नाम क्यों रखा था? बच्चे बड़े होते थे, 8, 6, 7, 4। तो और ये कब था? ये World War II के ज़माने की बात है, जिस ज़माने में औरतें ज़्यादा होती थीं। तो ये हिस्टोरिकली अगर आप जाएं तो 1964 तक जो पैदा हुए ना, वो बेबी बूमर्स हैं। इनमें काफ़ी बैठे हुए मुझे मिला के। उसके बाद फिर वो दूसरी जनरेशन एक्स आ गई और उसके बाद वाई आ गई, और ये खैर बहरहाल ये जनरेशन्स हैं। अब आजकल वाली जो जनरेशन है ना, टेक है होम मैसेज उनके लिए ये है कि अपने बड़ों की आप कदर करें, दे विल रिस्पेक्ट यू। अब बड़ों को भी चाहिए कि अपने बच्चों की रिस्पेक्ट करें, यू विल गेट दी रिस्पेक्ट। दिस इज़ एक जस्ट आपको बता रहा हूँ, ये आपकी कामयाब ज़िंदगी का राज है। बच्चों को बच्चा समझें, बाज़ औक़ात बच्चा भी आपको बहुत बड़ी बातें समझा देता है। बहुत शुक्रिया आपका।
सर ने बिल्कुल सही कहा। ऑब्वियसली दिस इज़ अ मैसेज फॉर मैनी ऑफ द मैन सिटिंग हियर एज वेल टू सपोर्ट देयर वाइफ्स। और ऑब्वियसली आपको प्रायोरिटाइज करना पड़ता है, जिस तरह डॉक्टर फ़हीम ने कहा, लाइक मी, आई हैव प्रायोरिटाइज फॉर माई कैरियर इन बिटवीन, जब बच्चे छोटे थे तो आपको थोड़ा टाइम उधर फोकस करना पड़ता है, एंड देन ऑब्वियसली वो टाइम गुजर जाता है, एंड देन यू कैन कंटिन्यू विथ योर कैरियर एज वेल. सो यू हैव टू प्रायोरिटाइज बिटवीन योर कैरियर वर्सेज योर किड्स. ऑब्वियसली वो भी बहुत ज़रूरी है कि आपने छोटे बच्चों को बहुत सारा टाइम देना होता है, तो उसके ऊपर भी कॉम्प्रोमाइज़ नहीं करना चाहिए. ऑब्वियसली कैरियर भी साथ साथ चलता रहता है, और आप एक वक्त के ऊपर आके दोबारा से उसी जगह पे आ जाते हैं. So I now call Dr. Humaira Mahmood to officially launch Women for Oncology. Ma'am, please. असल में मुझे मैसेजेस आ रहे हैं कि जी फ्लाइट्स हैं, तो वरना मैंने तो सोचा था अभी 10 मिनट और हम कुछ डिस्कशन कर लेंगे.
Thank you, Dr. Kuratulayan Badr. Again, thank you, Dr. Azhar. Okay, so officially on behalf of Pakistan Society on Clinical Oncology, I announce the launch of Women for Oncology Forum from today. So I have already mentioned the aims that we are focusing on, and this would help in our younger women to cope with the difficulties that they are encountering in their career. I was talking to Dr. Shahid Hamid in the morning, and I was mentioning that although we are going to launch Women for Oncology, but now we need something more for men for oncology, because now they are getting scarce. Now they are an endangered species, so we should also think of them as well, side by side. And this forum of oncology is not only meant for oncologists, but for medical physicists and RTTs, as well as our nurses, because all of us are working as a multidisciplinary team. So already Dr. Kuratulayan Hashmi has made a list of almost all female workers working in different hospitals of the country, no matter they are nurses, they are radiotherapy technologists, medical physicists, or radiation oncologists. I would like to thank the team who was behind launching this forum, particularly Dr. Kuratulayan Badr, Kuratulayan Hashmi, Dr. Maria, and Fatima Shaukat, as well as Rahila. They were all very ambitious and enthusiastic, and they had some very good ideas, though we couldn't go by those today because of the time constraint, but inshallah, as the time goes by, we are planning multiple activities for our younger women. So thank you all. Thank you.
Thank you, ma'am. आप में से अगर किसी को प्लीज़ कोई क्वेश्चन करना है पैनल से, तो यू आर ओपन, बिकॉज वी हैव 3-4 minutes we can give. Otherwise we have to close at 1:30. अभी हमारे पास काफ़ी टाइम है, बट इफ़ यू कंसीडर द फ्लाइट्स का भी स्केड्यूल भी देख लें तो हम कर सकते हैं. बट अगर फिर भी आप में से कोई भी 1-2 क्वेश्चन करना चाहता है, द पैनल, द डिस्कशन इज ओपन. Any resident, anyone from the RTTs, many of the RTTs are sitting here, the physicists, medical physicists are sitting here. If you want to ask anything. अच्छा, मैं चले पैनल से पूछ लेती हूँ. आप में से सबसे ज़्यादा चैलेंजेस किसको फेस करने पड़े बैलेंसिंग द वर्क और लाइफ? डॉक्टर मारिया या डॉक्टर सादिया बताएंगे. डॉक्टर सादिया, आपसे सुनते हैं कुछ आज. आपको आपसे हमने सुना नहीं है. माइक. डॉक्टर सादिया इज़ अ वाइफ ऑफ डॉक्टर असगर हुसैन असगर, फॉर दोज जिनको नहीं पता इस बारे में.
इतने कोई बहुत ख़ास चैलेंजेस नहीं फेस करने पड़े. आई एग्री विद डॉक्टर फ़हीम, सारी जो उनकी बातें थी. मुझे भी कभी खाना पकाने की मुश्किल नहीं पेश आई. अगर नहीं पका तो
ये गलत मैसेज जा रहे हैं. सारी लड़कियां घर जाके कहेंगी कि हम तो सुन के आएंगे खाना नहीं पकाना.
लेकिन जो मुझे एक सबसे बड़ा प्रॉब्लम फेस हुआ ये कि मेरे साथ कोई फैमिली नहीं थी, ना मेरे इन लॉज थे ना मेरे पेरेंट्स थे. तो जब बच्चे छोटे होते हैं तो मुझे हमेशा मेड्स पे भरोसा करना पड़ा. और ये पाकिस्तान का कल्चर है कि हमें हमेशा इस तरह की मेड्स मिलती रहीं कि उन्होंने मेरे बच्चों को संभाला पूरा दिन. तो और इससे ज़्यादा कभी कोई इतना प्रॉब्लम नहीं.
डॉक्टर फातिमा, आप कुछ ऐड करना चाहें? सर नहीं, इनके मियाँ डॉक्टर नहीं है, इसीलिए इनसे ये सवाल किया, क्योंकि ये एक अच्छी एग्जाम्पल हो सकती है.
ओके सो मेरी एक इम्पॉर्टेंट पॉइंट ये है कि फैमिली सपोर्ट डेफिनेटली इट्स वेरी इंपॉर्टेंट. अदर देन दैट workplace support is also equally important to for your growth as a leader or for your growth in grooming. अगर workplace में आप खुद as a team player नहीं हैं तो आप आगे चल के भी कुछ और नहीं कर सकते. एक इंडिविजुअल की ग्रोथ नहीं हो सकती आप जब भी परफॉर्म करें. ये मेरी अपनी लर्निंग है जो मैंने अपने मेंटोर से सीखी है कि यू ऑलवेज लर्न इन अ टीम. यू नीड अ सपोर्टिव सिस्टम. एंड इफ़ वी आर लीडिंग एनीवेयर यू हैव अ बैकअप टीम जो कि आपकी क्लिनिकल चीज़ को देख रही होती हैं. आपकी क्लिनिकल पेशेंट सैक्रिफाइस नहीं हो रहे थे. सो इट्स नॉट ओनली अबाउट फैमिली जो आपको सपोर्ट कर रही होती है. तो आपकी वर्क प्लेस की इक्वल सपोर्ट इम्पॉर्टेंट है.
बिल्कुल. डॉक्टर राहिला.
डॉक्टर कुरत, मैं सेम डॉक्टर फातिमा के बात को आगे बढ़ाऊंगी कि सिर्फ फैमिली सपोर्ट ही नहीं होती, आपका वर्क प्लेस सपोर्ट भी होता है. और मैंने तो अपने बच्चों के साथ ही अपनी एजुकेशन भी कंप्लीट की. जब मैं प्यास गई थी एमएस के लिए तो मेरी बेटी 1 साल की थी. तो फैमिली सपोर्ट भी थी मुझे और प्लस ये कि वर्क प्लेस पे जो बहुत अच्छे टीचर, बहुत अच्छे मेंटोर मिले जिन्होंने मुझे बहुत सपोर्ट किया. और अल्हम्दुलिल्लाह एक फेस आपको फीमेल का नज़र आता है लेकिन उसके पीछे एक पूरी फैमिली होती है. बहुत सारे लोग होते हैं जो उनके साथ स्ट्रगल कर रहे होते हैं.
और आपको वही बात है कि बहुत सारे चैलेंजेस नज़र आ रहे हैं. लाइक डॉक्टर राहिला ने जिसने बताया कि उनकी बेटी 1 साल की थी, तो आप में से बहुत सारी ऐसी हैं लड़कियां जो यहाँ पे बैठी होंगी जिनके इससे भी छोटे बच्चे होंगे. तो प्लीज़ आप घबराने की ज़रूरत नहीं है, ये टाइम पास हो जाएगा.
मैं उन्हें उससे छोड़ के गई थी घर पे. मैं वो कराची में थी और मैं इस्लामाबाद में.
डॉक्टर मारिया.
अस्सलाम वालेकुम. अच्छा, मैं डॉक्टर हुमैरा ने भी बहुत इंपॉर्टेंट पॉइंट्स डिस्कस किया. डॉक्टर फातिमा ने भी एक बहुत इंपॉर्टेंट पॉइंट जो है वो रेज़ किया कि आपको फैमिली की सपोर्ट भी चाहिए होती है, साथ में आपको अपनी वर्क प्लेस की टीम की सपोर्ट भी चाहिए होती है. मैं एक और चीज़ इसमें मेंशन करना चाहूँगी कि वर्क प्लेस भी आपको तभी सपोर्ट करेगी, फैमिली भी तभी सपोर्ट करेगी व्हेन यू रिफ्यूज़ टू स्टेप बैक. So you have to stand tall in the face of and you have to stand tall in the face of challenges and you have to be resilient. मेरे पास 3 बच्चे थे under 2 at one point. I had 3 under 2 क्योंकि उसमें से एक set of twins था. तो definitely वो एक challenging point था and everyone was looking at me, even the people from my workplace and my family के what do you want? तुम क्या चाहती हो? Do you want to step back for a while? And I never wanted to make it an excuse. So मैं ये कहूँगी अगर आप खुद कोई excuse तलाश कर लेंगे ना तो फिर excuse आते चले जाएंगे. So as a woman आपको खुद को भी बहुत resilient होना पड़ता है in the face of challenges. और जहाँ तक कुकिंग का ताल्लुक है तो मुझे ऑनेस्टली अगर कोई मुझे कहे कि बिरयानी बना दो तो मुझे नहीं पता कैसे बनती है. मैं कुछ ना कुछ बना ज़रूर देती हूँ, ठीक है, और वो पैलेटेबल भी होता है, लेकिन वो नाम से मुझे आज तक कुछ नहीं बनाना आता. तो ये कोई ऐसी बात नहीं है कि ख़वातीन को खाना बनाना ही
बनाने में आ गया है, ऐसा नहीं है. बहुत सारी हमारी ऐसी फीमेल्स हैं ऑब्वियसली हु आर अ वेरी, आई थिंक दे आर बेटर कुक. सो उनके लिए, सबके लिए तालियां जो घर में खाना बनाती हैं.
तो ये है कि वक्त की सबसे अच्छी बात ये होती है कि अच्छा हो बुरा हो हमेशा गुजर ही जाता है. एंड व्हेन एवर यू आर फेसिंग चैलेंजेस तो अपने से ऊपर नहीं अपने से नीचे देखें कि शायद मुझसे भी कोई डिफ़िकल्ट टाइम में होगा. सो जब वो कोप अप कर रहे हैं तो हम भी कर सकते हैं.
बहुत सारी चीज़ों को कॉम्प्रोमाइज़ करना पड़ता है, स्पेशली नींद को. डॉक्टर कुरत. आज
थैंक यू सो मच डॉक्टर कुरतुलैन. जिस तरह से सब लोगों ने बात की है चैलेंजेस की, तो मेरी ज़िंदगी में भी इसी तरह से ही चैलेंजेस रहे हैं. मैं एक्चुअली 2 प्रोफेशन के साथ हमेशा अटैच रही हूँ. वन इज़ माई मेडिकल प्रोफेशन एंड द अदर वन इज़ माई रेडियो प्रोफेशन. और सिंस आप ये समझ लें कि व्हेन आई वाज इन फाइनल ईयर MBBS देन आई जॉइंड FM 103 रेडियो फॉर द फर्स्ट टाइम. और हमारे साउथ पंजाब की पहली फ़ीमेल FM 103 की आवाज़ मेरी आवाज़ है. और उस वक्त से लेके आज तक ये 2 प्रोफेशंस जो मैंने साथ चलाए हैं, उसमें जो मेरे लिए सबसे बड़ी जो सपोर्ट है वो इस वक्त यहाँ इसी हॉल में मौजूद हैं मेरे हस्बैंड, जो अपनी सारी कमिटमेंट्स छोड़कर मेरे साथ इस PSCO के लिए भी स्पेशली आए हैं सिर्फ मेरे लिए. तो मेरी ग्रोथ में मेरी अम्मी और मेरे हस्बैंड ये 2 सपोर्ट हमेशा मेरे साथ रहे हैं और इनके बग़ैर मैं कुछ भी नहीं. और आज मैं जो कुछ भी हूँ इन्हीं की वजह से हूँ. ये ज़रूर है, कुरतुलैन पूछ रही थी खाना बनाने का, तो मुझे भी कभी किसी ने खाना बनाने का नहीं कहा। मुझे तो मेरे हस्बैंड ने कभी ये भी नहीं कहा कि मेरी कबर्ड जो है वो सही कर दो। मुझे पता भी नहीं है उन्होंने क्या पहनना है क्या नहीं पहनना। तो ये उनकी तरफ से मेरे लिए एक ब्लेसिंग है कि वो हर चीज़ के लिए वो खुद इतने इंडिपेंडेंट है, उन्होंने कभी किसी चीज़ के लिए डिपेंडेंसी शो नहीं की और हमेशा मुझे स्पेस दी है कि मैं जितनी फ्रीडम के साथ ज़िंदगी में आगे बढ़ सकूं। और उसके बाद आते हैं टीचर्स, जिनसे मैंने बहुत कुछ सीखा है मेरी ज़िंदगी में। मेरे उस्तादों का बहुत बड़ा रोल है, जिनमें से 2 उस्ताद तो यहाँ मौजूद हैं इस वक्त इस हॉल में, डॉक्टर फ़हीम एंड डॉक्टर हुमैरा। मैंने इनको हमेशा आइडियलाइज़ किया है अपनी ज़िंदगी में और कोशिश की है कि इनसे जितना टाइम इनके साथ स्पेंड हो, कुछ ना कुछ मैं लेकर ही जाऊँ और अपनी ज़िंदगी में वो ज़रूर इम्प्लीमेंट करूँ। तो आपकी फैमिली सपोर्ट, आपके टीचर्स, आपकी वर्क प्लेस की सपोर्ट, ये हमेशा आपके लिए बहुत ज़रूरी है आपकी ग्रोथ के लिए। थैंक यू सो मच।
इसकी लाइव ब्रॉडकास्ट हो रही है, सारी ख्वातीन आज घर जाके अपने हस्बैंड्स को इसकी रिकॉर्डिंग दिखा सकती हैं। डॉक्टर राफिया प्लीज़ कम। डॉक्टर हिरा को भी कुछ ऐड करना है प्लीज़। डॉक्टर हिरा, डॉक्टर अजहर, बस हमें 20 मिनट चाहिए और
थैंक यू सो
हम
मच।
1:30 से पहले क्लोज करेंगे।
थैंक यू वेरी मच। एक चीज़ जो मैं ऐड करना चाहूँगी, हम बहुत बखील हैं। हम बहुत बखील हैं कि हम एक दूसरे को अप्रिशिएट नहीं करते। अगर हम आपस में एक दूसरे को अप्रिशिएट करें, स्पेशली एक फ़ीमेल दूसरी फ़ीमेल को, दैट वुड बी रियली हेल्पफुल। डॉक्टर कुरतुलैन बदर, कल आपकी एक ट्रेनी की प्रेजेंटेशन थी। आई सॉ you stood up, you gave her thumbs up and you clapped for her, and I felt so proud of you.
So she was not my resident, she is Dr. Sameer's resident, but I like her a lot, so that's why I stood up and
we
gave
need
her
to
a
appreciate each other.
Standing ovation, because she's at that level in which she needs encouragement.
So ये चीज़ बहुत ज़रूरी है कि अगर आप एक खातून की तारीफ़ कर दें, वो कुछ भी कर सकते हैं।
बिल्कुल
Thank you so much.
बिल्कुल सही कहा। डॉक्टर राफिया, आप कुछ ऐड करना चाहती हैं? जस्ट 1 मिनट, सॉरी। जी, ये माइक है इधर, माइक।
मैं सिर्फ ये कहना चाह रही थी कि मेरे साथ डॉक्टर राहीला ने मुझे ज्वाइन किया था AEMC कराची में, और बस सिर्फ ये था कि इन्होंने मेरे साथ बहुत अच्छा लाइजन क्रिएट किया कि मतलब बिल्कुल ऐसा लगता था मुझे कि जैसे मैं इनका मैका हूँ, ठीक है। और जब मैंने इस्लामाबाद में ट्रांसफ़र हुई और मैंने नूरी ज्वाइन किया, तो मैंने ही वो लाइजन मैडम हमारा के साथ कायम कर लिया। मैंने अपनी हर चीज़ इनके साथ शेयर की, तो वो मुझे बड़ी आसानी रही मेरे अपने प्रॉब्लम्स में, उसमें कि मुझे आज ये करना है, मुझे वो करना है। तो इन्होंने वाकई मेरा हर लम्हे पे साथ दिया। तो मैं अपने यंगर जो जितनी ख़वातीन हैं, यंगस्टर्स, उनको ये कहूँगी कि अपने मेंटर और अपने सुपरवाइज़र के साथ प्लीज़ बिल्कुल सच्चा राब्ता रखें और उनसे मशवरा करते रहें, और आप बिल्कुल इसमें नाकाम नहीं होंगे इंशाल्लाह।
नाउ वी मूव फॉरवर्ड टू आवर सर्विस अवार्ड। डॉक्टर अस्मा प्लीज़, कुछ कहना चाह रही हैं? अच्छा, अल्लाह खैर करे।
अस्सलाम वालेकुम एवरीवन। मैं डॉक्टर अस्मा हूँ, मैं डॉक्टर कुरतुलैन की ट्रेनी हूँ, और आप सबकी बात सुन के मैं कुछ चीज़ें ऐड करना चाह रही हूँ। आप सबसे मैं एग्री करती हूँ कि हमें अपनी ट्रेनिंग में बहुत सारी डिफ़िकल्टीज़ फेस करनी पड़ती हैं, और टू बी वेरी ऑनेस्ट, जब मैंने ट्रेनिंग ज्वाइन की थी तो मैं अपने ट्विन्स जो है 1 साल के 2 बच्चे घर छोड़ के मैंने ज्वाइन की थी। और डॉक्टर कुरतुलैन ने जो है, जब मैंने उनको ये चीज़ बताई थी, शी वुड बी द फर्स्ट पर्सन who said to me कि you are gonna do it. She was the one जिसको ये इस चीज़ पे भरोसा था कि तुम ये कर लोगी। And throughout मुझे बहुत सारे challenges face करने पड़े, और शायद डॉक्टर कुरतुलैन अगर नहीं होती तो मैं ये ट्रेनिंग कंप्लीट नहीं कर पाती।
चलें, पगली रुलाएगी क्या?
Thank you so much.
अच्छा, ओके, सो नाउ वी मूव फॉरवर्ड टू आवर सर्विस अवार्ड। प्रेजेंटेशन प्लीज़ लगा दीजिएगा। Some careers are measured in years, but some lives are measured in the difference they make. Today, we honor a woman whose journey in oncology is not just a professional timeline, but a story of vision, courage, and quiet strength. Dr. Tehseen Fatma joined the Pakistan Atomic Energy Commission in 1980, at a time when oncology itself was evolving, and women leaders in this field were rare. As a young medical officer at AEMC Jamshoro, she embraced the challenge of cancer care with dedication, mastering radiotherapy, brachytherapy, chemotherapy, and the holistic management of cancer patients. My father is also sitting in this picture. I can see him. He's standing just on the left, okay. Her commitment soon carried her to Noori Islamabad in 1996, where for over a decade, she led the radiotherapy department. There, she not only worked with advanced technologies, with linear accelerators and LDR, HDR brachytherapy, but also built systems, teams, and future. She established oncology wards, strengthened training pathways, and played a vital role in achieving CPSP accreditation, shaping generations of oncologists through FCPS and MCPS training. When entrusted with the responsibility of establishing radiotherapy at Kiran Hospital, Karachi in 2006, she once again proved that leadership is not about position. It is about perseverance. Through tireless effort, she helped install simulators, treatment planning systems, and laid the foundation for modern cancer care. Her services were recognized with the first gold medal of PAEC, a testament to a career defined by excellence rather than applause. Promoted to Deputy Chief Medical Officer and later serving as Director Kiran, Dr. Tehseen Fatma's legacy is written not only in institutions she built, but in lives she touched, students she trained, and hope she sustained. Today, in this Women for Oncology session, we proudly celebrate a woman who stood strong when paths were unpaved, who led with grace in demanding times, and who became a beacon for women in oncology across Pakistan. Dr. Tehseen Fatma, this service award is a small tribute to a lifetime of dedication, leadership, and healing. Your journey inspires us. Your legacy lives on. Dr. Fahim, sir, please. Dr. Abrar Ahmed Javed, sir, please, if you come on the stage to give a shield. Dr. Humaira, ma'am, please, aap aiye.
सर डॉक्टर शाहिद हमीद सर आप किधर हैं सर सर प्लीज़ आ जाओ लास्ट फ्यू जॉब्स ऑन द स्टेज सॉरी फॉर दैट
बैठे 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 सर, बस वीडियो, हाँ बैठे अभी तो बैठे. प्लीज़ द पैनल प्लीज सिट ऑन द स्टेज. So can we move forward, sir? Sir, please. So women who are working in oncology, either as consultants, residents, physicists, nurses, and RTTs, for those, to honor them, we have compiled a video. Please, please show that video. Thank you.
के कुछ कहानियाँ कभी अखबारात की सुर्खी नहीं बनती, कुछ जिद्दोजहदें ताल की आवाज़ के बगैर मुकम्मल हो जाती हैं। पाकिस्तान के ऑन्कोलॉजी वार्ड्स में ऐसी ही खामोश कहानियाँ रोज़ लिखी जाती हैं और इन कहानियों की मुसन्निफ़ अक्सर एक खातून होती है। वो खातून जो सफ़ेद कोट में अपने दिल के सारे रंग छुपाकर दूसरों के दुख संभालती है, रोज़ खुद को भुलाकर दूसरों को ज़िंदगी याद दिलाती है। वो ऑन्कोलॉजिस्ट हो, नर्स हो, फिजिसिस्ट हो, रेडियोथेरेपिस्ट हो, रिसर्चर या ट्रेनी, उसकी पहचान सिर्फ एक है, हौसला। ऑन्कोलॉजी में काम करना सिर्फ एक पेशा नहीं, ये सब्र का इम्तिहान है, हौसले की इबादत है और इंसानियत की सबसे मुश्किल खिदमत। ये वो ख्वातीन हैं जो मुश्किल खबर सुनाते हुए अपनी आंखों के आंसू रोक लेती हैं, जो रेडियोथेरेपी रूम के बाहर एक खौफजदा मरीज का हाथ थामकर उसे तन्हा नहीं होने देती, जो दिन के इख्तिताम पर अपनी थकन को खामोशी से समेटकर घर की दहलीज पर एक और किरदार निभाने लगती हैं, माँ, बेटी, बीवी, बहन। मगर दिल में अभी भी वही मरीज रह जाता है जिसने जाते जाते कहा था, डॉक्टर साहिबा दुआ कीजिए। ये ख्वातीन कैरियर और घर के दरमियान पुल बनाती हैं। ये ख्वातीन सिर्फ जिम्मेदारियां नहीं निभाती, ये तवाज़ुन कायम रखती हैं। पेशा वराना ज़िंदगी और घरेलू जिम्मेदारियों के दरमियान खुद को पीछे रख कर दूसरों के लिए मौजूद रहने का हौसला। फिर भी ये हर रोज़ आती हैं मुकम्मल जज्बे के साथ। ये क्लिनिक्स चलाती हैं, रिसर्च करती हैं, नई नस्ल की रहनुमाई करती हैं और मरीज़ों को और उनके ख़ानदानों के साथ उनके सबसे मुश्किल लम्हात में खड़ी रहती हैं, मगर शिकवा नहीं करती। कराची के मसरूफ़ अस्पतालों से लाहौर के रिसर्च सेंटर्स तक, इस्लामाबाद, पेशावर, कोयटा, मुल्तान और पाकिस्तान के बेशुमार शहरों में ये ख्वातीन ऑन्कोलॉजी की नब्ज़ थामे खड़ी हैं। कुछ ख्वातीन कॉन्फ्रेंस स्टेजेस पर नज़र आती हैं, बहुत सी पसपर्दा खिदमात अंजाम देती हैं, कुछ नामों के साथ पहचानी जाती हैं, कुछ सिर्फ अपने काम से, कुछ रोशनी में होती हैं, बहुत सी साए में, मगर हर एक मरीज़ की ज़िंदगी में उम्मीद की एक किरण छोड़ जाती है। आज ये लम्हा आपके नाम है। हम आपकी मेहनत को सलाम पेश करते हैं। हम आपके ज़ब्त, आपके हौसले और आपकी बेलौस खिदमत को सराहते हैं। आप सिर्फ कैंसर का इलाज नहीं करती, आप टूटते दिलों को सहारा देती हैं, बिखरती उम्मीदों को जोड़ती हैं और अंधेरे में रोशनी बन जाती हैं। विमेन फॉर ऑन्कोलॉजी महज एक सेशन नहीं, ये एतराफ़ है कि ऑन्कोलॉजी में औरत की मौजूदगी रहमत है, कुव्वत है और रोशनी है। पाकिस्तान की तमाम ऑन्कोलॉजी में खिदमात अंजाम देने वाली ख्वातीन के नाम आप देखी जा रही हैं, आप महसूस की जा रही हैं और आपकी खामोश जिद्दोजहद हम सब के लिए बाइसे फ़ख्र है। शुक्रिया आपकी हिम्मत का, आपके सब्र का और इंसानियत के लिए आपके बेआवाज़ इश्क का। विमेन फॉर ऑन्कोलॉजी, जहां औरत उम्मीद बन जाती है।
चले उस बादल पे, उड़े उस आंचल पे, हमारे हाथ है दुनिया, हमारे साथ है दुनिया, हम अपने गीत लिखेंगे, हम अपनी रीत लिखेंगे। चल पड़ी तो किस रस्ते ओ दीवानी, तू कलम खुद लिख ले अपनी कहानी, किस्मत की लकीरें छोड़ दे, तेरी भूख से बदले रोज ये, झूठी पड़ जाए ये दुनिया सारी, तू नहीं कमजोर आ लगा ले जोर, कर बुलंद परचम में से हमारा, के देखे दुनिया तेरी हिम्मत ऐसी, जुस्तजू तेरी नाजुक कह के वार करे जो, तोड़ दे उंगली रस्में सारी तोड़ के आए, अब सुने मन की मिट्टी की गुड़िया ना समझे, अब हमें कोई एहसास, ये तेरे कदम पहचान, तू सिर्फ़ आहम। रोके ना भी तू रुक ना पाए, कर ले खुद से ये है, चूड़ियों की जंजीर को तोड़े, उम्मीदों की एक लहर, सीखा मैंने अपने आप भी जीना, मुझ में है ये दम, है मुश्किल रास्तों पे चलना, भूल के सारे गम, इरादे तेरे हमको ये बताए, जीत का है अज़म, है दुनिया बोले जो भी हमको, है साथ रब हर कदम, तू नहीं कमजोर आ लगा ले जोर, कर बुलंद परचम में से हमारा, के देखे दुनिया तेरी हिम्मत ऐसी, जुस्तजू तेरी नाजुक कह के वार करे जो, तोड़ दे उंगली रस्में सारी तोड़ के आए, अब सुने मन की मिट्टी की गुड़िया ना समझे, अब हमें कोई एहसास,
नहीं है ना उम्मीद इकबाल अपनी कश्ते वीरा से, ज़रा नम हो तो ये मिट्टी बड़ी ज़रखेज़ है साकी. I'm grateful to Mr. Faraz and Mr. Razi from the media team for the thoughtful compilation of this video, and to all colleagues who generously shared their photographs for making this collective strong possible. The journey of women in oncology is incomplete without acknowledging the men in oncology who stood beside them as mentors, colleagues, leaders. And I extend my special thanks to all the men sitting out there, especially the senior management of PSCO, Dr. Abrar Ahmed Javed, Dr. Fahim, Dr. Asghar, especially Dr. Azhar Rashid, Dr. Ijaz, Dr. Rabnawaz Mekan, Dr. Ahmed Hassan Mahmood, for their unwavering support and belief in empowering women in oncology. Together, your support continues to strengthen our shared mission towards excellence in cancer care. Thank you so much, sir. Now I'll call Dr. Azhar Rashid for announcement of the winners of posters and the presentations. And I hope you all liked the video of Women in Oncology. इसके लिए हमने काफ़ी काम किया. मैं दिन रात रिमाइंडर्स भेजती थी, तो आई थिंक आप सबके मोबाइल्स उससे फिलअप हो गए होंगे. बट आई एम रियली थैंकफुल कि आप लोगों ने उसके लिए हमें सपोर्ट किया और अपनी पिक्चर्स भेजी. अगर किसी की रह गई हो तो उसके लिए मैं पहले से माजरत कर लेती हूँ कि अगर कोई हमसे मिस हो गया, इंशाल्लाह ताला उसको नेक्स्ट टाइम हम ज़रूर इनकॉर्पोरेट करेंगे. जज़ाकल्लाह. थैंक यू सो मच.
थैंक यू वेरी मच डॉक्टर कुरत. दोनों कुरत जो है यहीं पे रहेंगी प्लीज़. आपका हो गया, आप कुरत यहीं पे रहेंगे. बिकॉज द क्लोजिंग सेरेमनी के लिए जो हमारी मॉडरेटर हैं वो डॉक्टर कुरतुल एन हाशमी हैं. शी विल बी जस्ट हैविंग लाइक 5 to 10 minutes क्लोजिंग, एंड वी विल बी गोइंग टू द लंच एट अबाउट 1:30 आई गेस, 1:30 से 1:45 के दरमियान. अब जिनकी फ़्लाइट्स हैं उनके लिए माजरत. मैं क्विकली जो है अनाउंस कर दूं पहले, क्योंकि ये कुछ लोगों ने जाना है, इसलिए हमें बीच में जो है ना ये जो विनर्स हैं उनको अनाउंस करना है. सबसे पहले जो है जी हम पोस्टर प्रेजेंटेशंस को करेंगे. इसके लिए जो नंबर 1 का चेक है वो लेके आ जाए, और इसके साथ जो देने के लिए है मैं फिर एक दफ़ा रिक्वेस्ट करूँगा डॉक्टर इब्रार जावेद से और डॉक्टर शाहिद हमीद से, एंड दिस टाइम डॉक्टर शाहिद रसूल एंड डॉक्टर मोहम्मद फ़हीम, दे नीड टू जॉइन दैम. आप 4 का ग्रुप इधर आ जाएं प्लीज़. किसको बुलाना है? वुमेन इज़ गोइंग टू क्लोज नाउ. नहीं, it was really a very good session, and we will have a feedback from all of you कि how did you find this session, और उसके लिए कि इसकी continuity जो है next oncos में कैसी रहेगी, तो ये आप ज़रूर बताइएगा. To me, I really like this session. It was well formatted और बहुत structured था. डॉक्टर कुरत ने बड़ी मेहनत की है, and many of the ladies they actually took long time to get into this. तो अगली दफ़ा जो है आपने जल्दी से cooperate करना.
What will happen next time? Not in 27 or 28, maybe in 30, there will be a session men for oncology and women will be conducting it. Anyway, I am really glad to see Kuratul and Badar. She has arranged a wonderful show. And Azhar ने तो खैर कमाल कर दिया. ये दूल्हा हैं आज के, तो इनको बहुत मुबारक हो.
प्लीज़ आप जो पोस्टर्स के विनर हैं हम इस तरह से कर रहे हैं कि जो कैटेगरीज थी रेजिडेंट कॉर्नर, यंग ऑन्कोलॉजिस्ट एंड वुमेन फॉर ऑन्कोलॉजी कंबाइंड, मेडिकल फिजिक्स एंड रेडिएशन टेक्नोलॉजीज, 4 कैटेगरीज में 4 लोग आप इकट्ठे ऊपर आएंगे जिनका प्राइज़ नंबर 3 है 1 है. इट इज़ डॉक्टर अस्मा सलीम फ्रॉम रेजिडेंट कॉर्नर. यंग ऑन्कोलॉजिस्ट एंड वुमेन फॉर ऑन्कोलॉजी के लिए डॉक्टर हमाद. मेडिकल फिजिक्स के लिए जैनुल आबिदीन. रेडिएशन टेक्नोलॉजिस्ट के लिए उज़ैर अहमद. जो टेक्नोलॉजिस्ट हैं उज़ैर. सो दे आर द विनर्स. आ जाए सब लोग आ जाएं प्लीज़. 1 सारे के सारे इधर आ जाएं. एनीबॉडी एल्स जो कि 1 में है? अस्मा सलीम, हमाद, जैनुल आबिदीन, उज़ैर। For second position, resident corner Dr. कायनात। ये ले लें बॉस, ये उठा लें, ये ले लें, एक बंदा इधर भेजें। हाँ हाँ। For young women and women for oncology combined is Dr. Hifza. For medical physics, Uzma Ilyas. For radiation technologies, Hifza Zamir. अगर मौजूद हैं तो आ जाएं। सेकंड पोजीशन के 4 कैंडिडेट 4 कैटेगरीज में यहाँ आ जाएं प्लीज़। डॉक्टर कायनात, डॉक्टर हिफ्जा, उज़मा इलियास एंड हिफ्जा ज़मीर। यू मूव ऑन प्लीज़। So I'm just announcing the next people. Resident corner Maham Khalil. Young oncologist, woman for oncology, Dr. Wajiha. Medical physics, Hassan. आप थोड़ा सा वेट कीजिएगा, ये ख़त्म कर लें, आपका दूसरा चेक आएगा। For radiation technologies, Muhtasim. So position 3 वाले सब आ जाएं प्लीज़। डॉक्टर महम खलील, डॉक्टर वजीहा, हसन एंड मुहतसिम। एनीबॉडी लेफ्ट इस कैटेगरी में? चलें, गुड। Thank you very much. So we will go to the oral presentation winners. For position 1, resident corner, Shahzeb Javed. For young oncologist, Dr. Iram Idris. Dr. Iram Idris. Women for oncology, Dr. Kuratul N. Hashmi. Medical physics, Saida Naima Fatma. Radiation technologist, Ariba Naz. पोजीशन 1 वाले आ जाएं प्लीज़ जल्दी से। सेकंड वाले नाम देख लें, रेडी रहें। और थर्ड वाले भी रेडी रहे। सॉरी, आ जाएं, आ जाएं। Please, for second prize, Zainab Rafat, Dr. Zainab Rafat, resident corner. Young oncologist, Dr. Wajiha Anjum. For women for oncology, Dr. Fajar. Medical physics, Hamid Jamil. Radiation technologist, Syed Ashar Amjad. So third prize winners, resident corner, Dr. Tuba Ali. For young oncologist, Dr. Fatma Shaukat. Women for oncology, Dr. Maliha. Medical physics, Zainab Mustafa. And radiation technologists, 2 people achieve similar marks from the judges. I will take both of them. They will take full prize. Shagufta Tasneem and Sayyid Fatima. अगर हैं तो आ जाए. अभी और भी प्राइस तो नहीं है हमारे पास. हाँ बस ठीक है. That's fine, sir. Thank you very much. जी. कॉन्सुलेशन के प्राइस यार, कॉन्सुलेशन जो सर्टिफिकेट्स थे वो बताएं. 3 लोग थे. Number 1 is Dr. Paras. The consolation prize in poster presentation. Judges gave the special comments for 3 people for consolation. Dr. Paras, Hafiz Abdullah and Zoya. अगर यहाँ हैं तो आ जाएं. हाफिज अब्दुल्ला एंड जोया अगर हैं तो आ जाएं. चले, डॉक्टर पारस इज हेयर.
सर वो पूछ रहे
अगर she wanted to,
वो असल में पूछना चाह रही है पोस्टर है या टॉक है.
नहीं, this is a certificate. सर वो दे देना, वो हम इनको वो इलेक्ट्रॉनिक है ना, वो उनको उस पर भेज देंगे. Actually, all the certificates are electronic and we will be giving you 2 types of certificates. एक पार्टिसिपेशन और अटेंडेंस का सर्टिफिकेट है जो सोसाइटी इशू करेगी, वो आपकी ईमेल्स पे आएगा डायरेक्टली विद इन अ वीक. और जो CME के सर्टिफिकेट्स हैं वो कॉलेज की तरफ से आएंगे. दैट टेक्स यूजुअली 45 डेज़. वो भी आप लोगों की ईमेल्स पे आ जाएंगे. तो इसलिए कोई हमारे पास इस दफ़ा हमने कोई प्रिंटिंग का कोई नहीं किया हुआ है. सो दैट विल बी इलेक्ट्रॉनिक एंड डिजिटल. So thank you very much. I will hand over to Dr. Quratulain Hashmi for the formal closing. Thank you.
Thank you so much, sir. Now, ladies and gentlemen, respected colleagues, esteemed speakers, honorable guests, and my dear friends, very good noon. On behalf of Pakistan Society of Clinical Oncology, ONCO 2026, it's my great honor to welcome you to the closing ceremony of 27th Annual Cancer Congress, ONCO 2026. Over the past few days, we have shared knowledge, innovation, and inspiration, united by one goal: advancing cancer care and improving patient outcomes in Pakistan. So, stronger alliance, cancers defines. During these thrilling days of ONCO 26, we have explored cutting-edge developments in precision oncology, precision radiotherapy,
immunotherapy, stereotactic radiosurgery and radiotherapy, and with patient-centered approaches in our treatment. ONCO 26 has introduced Women for Oncology, the very colorful session of today, Young Oncologist, Radiation Technologist sessions, and I would like to extend our deepest gratitude to our distinguished international and national speakers, session chairs, panelists. Your expertise, your dedication, and your willingness to share knowledge made this Congress a remarkable success. So, a round of applause, please, for our respected faculty, ONCO 26. Now for an acknowledgement, as we know that this event, ONCO 26, it wouldn't have been possible without the tireless efforts of our assistants with, first of all, I would like to call upon on stage volunteers and medical support team for group picture. Please, जो लोग यहाँ पर available हैं, volunteers और medical support team से वो stage पर तशरीफ ले आएं, group picture के लिए. Volunteers and medical support team जितनी भी हैं इस hall में मौजूद, kindly come on the stage to have a picture. Dr. Azhar. सर्टिफिकेट्स आप सबको इलेक्ट्रॉनिकली मिलेंगे और ये ग्रुप पिक्चर के लिए आ जाएं प्लीज़. जी 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 जी.
We have already given them the souvenirs in the interest of time, so they will be in group form, they will take our picture.
ग्रुप पिक्चर के साथ इनके लिए भरपूर तालियां हो जाएं बिकॉज इन्होंने बहुत बहुत अनथक मेहनत से काम किया. Dr. Azhar यहीं रहेंगे. I would like to call upon on stage media cell and event management team. Kindly उनके जो भी यहाँ पर persons हैं stage पर आ जाएं for group picture. Media cell and event management team, please.
Dr. Ali और Dr. Aslam का पता करें हैं.
Dr. Ali, आप kindly stage पर आ जाएं. Dr. मोहम्मद अली सर आप please. और Dr. असगर साहब. मीडिया सेल और इवेंट मैनेजमेंट टीम के जो भी अफराद यहाँ मौजूद हैं काइंडली कम ऑन द स्टेज. Thank you so much. Now, this is time for the star of this event, ONCO 26. I would like to call upon on rostrum on stage the man of ONCO 2026, the sapphire, the star of ONCO 2026, very honorable, very vibrant, और इनके लिए मैं एक शेर भी लेकर आई हूँ जिसमें थोड़ी सी मैंने तरमीम की है। बर्क क्या, शरारा क्या, रंग क्या, नज़ारा क्या। बर्क क्या, शरारा क्या, रंग क्या, नज़ारा क्या। ONCO 26 के हर दिए की मिट्टी में रोशनी तुम्हारी है। I would like to call upon a huge hand of applause for Dr. Azhar Rashid.
ये लास्ट है ना, ठीक। थैंक यू वेरी मच डॉक्टर कुरत। काफ़ी दिनों के बाद थोड़ा सा रिलैक्स मैं ख़ुद को महसूस कर रहा हूँ, बिकॉज आई हैव अ गुड स्लीप येस्टरडे, एंड आई एम वेरी ग्रेटफुल टू माई वेरी सीनियर रिस्पेक्टेड चीफ गेस्ट एंड आवर पैट्रन डॉक्टर शाहिद हमीद एंड डॉक्टर इबरार जावेद साहब, जिन्होंने बहुत कंसिस्टेंटली हमारे साथ जो है काफ़ी सारे दिनों में बड़ी हेक्टिक जॉब्स की हैं, बार बार स्टेज पे आए और बार बार वो आगे पीछे मूव करते रहे, और पर्टिकुलरली कि दे वर बोथ वर प्रेजेंट इन ऑल द साइंटिफिक सेशंस। आई एम ग्रेटफुल टू बोथ ऑफ देम प्लीज़। और ये इंस्पिरेशन है कि जब आपके सीनियर्स होते हैं तो बाकी सब लोग भी खुद ब खुद आ जाते हैं सेशन में। सो मैं आज के लिए सिर्फ आई एम ग्रेटफुल टू एवरी वन प्लीज़। अभी हमने इसको शॉर्ट करना है क्योंकि काफ़ी सारी फ़्लाइट्स है और हम खाने का इंतज़ार कर रहे हैं। मैं सिर्फ शुक्रिया अदा करूँगा वो तमाम लोग जिन्होंने मेरे साथ कोऑपरेट किया। उसमें मेरी एग्जेक्टिव काउंसिल, मेरे साथ डॉक्टर असगर या डॉक्टर अली और इनके साथ साथ जितनी टीम थी, हम अच्छा कर सके या बुरा कर सके, बट वी ट्राइड आवर लेवल बेस्ट एंड वी विल इम्प्रूव लॉट ऑफ थिंग्स नेक्स्ट टाइम इंशाल्लाह। जो अच्छी हैं आप ज़रूर फीडबैक दें, जो आपको लगता है नेगेटिव हैं वो आप हमें पॉइंट आउट ज़रूर करें। वी विल ट्राई टू मेक अ गुड करेक्शंस ऑन दैट। माई फैमिली, पर्टिकुलरली माई वाइफ, शी वॉज सफर्ड क्योंकि मैंने पिछले 2 महीने बिल्कुल लिफ्ट नहीं कराई। सो शी वॉज वेरी इरिटेटिंग कि आप टाइम नहीं दे रहे हैं आजकल, शाम में भी सुबह भी आप फ़ोन पे लगे रहते हैं। सो आई एम थैंकफुल टू माई फैमिली, मेरे बच्चों के साथ, और बहुत तमाम लोग जो यहाँ पे आए जिन्होंने अटेंडेंस दी, और सब लोगों ने जिन्होंने हमें बहुत सपोर्ट किया, पर्टिकुलरली द स्पीकर्स, पैनलिस्ट, आवर साइंटिफिक एजेंडा में आने वाले लोग, और फिर बाकी सब लोग जो मैनेजमेंट में रहे, और होटल से लेके मीडिया और इसके साथ साथ हमारे इवेंट मैनेजर, सब लोगों का बहुत शुक्रिया। और एग्जेक्टिव काउंसिल, पर्टिकुलरली माई वेरी गुड एंड वेरी सीनियर फ्रेंड्स डॉक्टर फ़हीम, डॉक्टर हुमैरा और डॉक्टर शाहिद रसूल जो सामने बैठे हैं, इन समेत सब लोगों का बहुत शुक्रिया। आई विल फिनिश एंड वी विल हैव अ lunch for the faculty in the Ambassador 3 and remaining will be in the foyer. Thank you very much. और किसी भी गलती के लिए माफ़ी फरमाइएगा। We are done, Dr. Saiba.
2025 खत्म हो गई।
So dear, as we conclude this Congress, let us take home not only new knowledge, but also renewed commitment to research, to compassion and excellence to oncology care. Good times. एक ग्रुप फोटो के लिए प्लीज़ इस वक्त जो लोग मौजूद हैं प्लीज़ फैकल्टी के इधर आ जाए, जो भी आ जाए हमें ज्वाइन करें यहाँ स्टेज पर ग्रुप फोटो के लिए। डॉक्टर अजहर प्लीज़ ग्रुप फोटो के लिए सब लोग आ जाएं जो इस वक्त